Hi, everyone. Welcome to Research Day. I hope everyone can see me. I see my videos on, but I can't see me, so I'm not sure what's going on there. Okay, there, it's fixed. Welcome, everyone, to Research Day. This is our first and hopefully last ever virtual Research Day. As many of you know, every year we host Research Day as a live event where we share lunch and stimulate each other with ideas and current ongoing projects and such. So hopefully we will return to that once again next year in 2022. I want to welcome you all here. Hopefully, we have 55 people so far. That's great. Hopefully, we'll have more coming in, and we've certainly invited everyone from Presby and Hop and our other sites as well. We have some screens scrolling here just to give some information about CME and CE credits. And I would ask Rachel McFadden, who is our nursing CE manager, if she could post the link in the chat thread. That would be great. For any of the nurses joining, you can claim CE credits. For any of the physicians joining, you can claim CME credits just as you would on one of our regular Wednesday conferences. And you should have all received notice from Kevin Scott about how to claim CME credits. So we've decided to have a somewhat shortened research day this year because having a very long Zoom call is, of course, something we're all overburdened with already. So the program today will go from around 9 in the morning till around 12:30 p.m. if we stick on schedule. We will have a keynote presentation from Dr. Harrison Alter. We're thrilled to have him, and shortly I'll ask Dr. Caitlina Stillman to introduce him. We will have faculty from various Penn EM research centers speak about their programs at 10 a.m. And then 11 a.m. we will have presentations of original scientific abstracts. So that should be exciting. The way this Zoom meeting is going to run, just a little note on the mechanics. It's a regular Zoom meeting, not a Zoom webinar. So you have full access to the chat thread. We have disabled everyone's video and audio just because there's a lot of people and we want to keep this organized. If you do wish to ask a question, put it in the chat thread and we can help organize those questions to the speakers. If you're a speaker today, you will be made a co-host and you will have the ability to turn on your video and audio. Therefore, being mindful when you're not speaking to have the video and audio off so that we don't hear a lot of background noise. Okay, I think that's all the mechanics today. I wish I could tell you about our lunch that we'll be serving. Sadly, lunch is, of course, on your own. I do want to thank our three sponsors. We have three vendors as sponsors today, and we're very thankful for their generosity to support us. One is Mindray, and you all have used Mindray ultrasound equipment in the ER. The other is Becton Dixon, and certainly you've all used the Arctic Sun device during post-arrest care in the emergency departments at Hop and Presby and elsewhere. And then our third sponsor, Butterfly, as a sponsor, and you've certainly all used Butterfly equipment as well. So we thank them for their support and their ongoing collaboration. Some of them are listening in today to the proceedings. Okay, with that, I'm going to turn it over for some brief remarks from our chair, Dr. Ben Sun, and following that, we'll have Dr. Stillman introduce our keynote speaker. Dr. Sun, the floor is yours.
Thanks, Ben. First of all, I wanted to thank you and your team for organizing this wonderful event. I wanted to thank all the participants in a novel format, and I think that all of the participants will get a tremendous amount out of this experience. And finally, I did want to thank Dr. Alter for agreeing to be our keynote speaker. So enjoy. I'm going to turn it over to Caitlina.
All right. Hi, everyone. Looks like my video isn't working. Can everyone see me? All right. I will go ahead. I'm very thrilled to introduce to you all today this year's Penn EM Research Day keynote speaker and a longtime mentor of mine, Dr. Harrison Alter. Dr. Alter received his medical degree from UCSF, his master's degree in health and medical sciences from UC Berkeley, and was a Robert Wood Johnson Clinical Scholar at the University of Washington. He is a clinical associate professor of emergency medicine at UCSF and has been an attending emergency physician at Highland Hospital, Alameda Health System since 2004. Prior to his current appointment, Dr. Alter served as an associate chair for research at Highland and as faculty of emergency medicine at the University of Washington and its Harborview Injury Prevention and Research Center. Notably, Dr. Alter is the founding executive director and director of research at the Andrew Levitt Center for Social Emergency Medicine. In creating the Levitt Center, Dr. Alter established a new research and advocacy realm within emergency medicine, incorporating matters of social and structural determinants of health and many other disparate elements into the concepts of social emergency medicine. Thank you, Dr. Alter, for being here today and for joining us so early on the West Coast.
Thank you for that kind introduction, Caitlin. It's so great to be here. Let me figure out how to share my screen here, and then we can get started. So it's such a privilege to be here. I have to say, a little intimidating to be at Penn on Research Day, such a vaunted institution in the annals of research and emergency medicine. So many practice-changing developments arose here, and particularly in social emergency medicine. The work that's being done at Penn today by Dr. South, Dr. Killaroo, Dr. Mizell, I mean, so many people, Dr. Merchant, Dr. Delgado. So much of what's being done here today is defining the conversation in social EM, but also for what's come before. I mean, some of the real OGs in social emergency medicine did their formative work here. I'm thinking in particular of Bob Lowe, who really helped define the field in the late 80s, early 90s into the 2000s. Much of that work done here at Penn. And of course, Karen Rhodes. I don't know how many of you heard Dr. Rhodes talk yesterday at the SAEM Social Emergency Medicine Consensus Conference, but she walked through her pioneering career in social emergency medicine, and so much of that fundamental work was done here at Penn. So I really do feel that I'm here in a hall of giants, and you know, it's the air is pretty thin up here. So thanks so much for this privilege and the honor of this award, and I can't tell you that how much it means to me. So the title of my talk, I left the title slide up here for a little bit because you do, I'm sure, infer a little bit of battle scars in the title. This goes back, you know, probably 15 years to when we were writing our first grants to for the inception of the Levitt Center. And you know, for years we would get responses back, you know, on our second, third, fourth submissions, you know, impeccable package, very well assembled proposal, doubt its relevance to emergency care. So I think many of us in the field recognize that social emergency medicine is having a moment, and it has to be in part a silver lining of the pandemic. It's also in part a benefit arising from the conversation started by Black Lives Matter over the past 5 or 6 years, and culminating this past year, and other elements within the social justice movement in the US have really given oxygen to social emergency medicine. And so I want to walk through some of that progression today. I do have to make some corrections to Caitlin's generous introduction. I retired from Alameda County Healthcare for the Homeless in January after directing the COVID-19 response for under a year, 10 months. That was a planned retirement. I think I've seen my last patient in the Highland Hospital Emergency Department. I'm not 100% sure of that. I still am connected to the Levitt Center deeply. So that is unchanged. I have no financial conflicts to disclose. I think it's important to disclose the privileged position I'm speaking from today as a white cis male and somebody who's benefited at every step from born privilege in the education and training system to be able to stand on this platform today. So although it's not strictly speaking a conflict of interest, it is something that I wish to disclose. I know how EM conference goes. I've been to a few of them. You'll get paged out. There'll be a code on the floor. The trauma team will respond to the emergency department. So for those who get called away, I just want to put the take-home points up front and dispose of any suspense that may build up. So this is the important thing to know. These are the important points to know walking out of here today. We've known about health inequities based on racial and ethnic and economic considerations for many, many years. And so these are not new. They have been somewhat relegated to a corner of medical research until now. And the striking disparities in COVID-19 infection and death have brought these to a much wider audience. These health inequities, although they seem to be based on characteristics of individual people, are really driven by social forces and structural forces beyond the individual. And these forces include obviously housing and hunger and exposure to systemic racism and many other social forces that create these health inequities within the medical care system. It turns out that some of these social forces, especially the social drivers to emergency care, may be amenable to intervention in the emergency department. And we all know the role that the emergency department serves within the medical care system as the safety net. Lastly, by establishing relationships with community partners, emergency departments can offer social health initiatives to complement our physical health and behavioral health stabilization practices. In other words, moving from the dyad of physical health and mental health stabilization that we currently typically perform in the emergency department to a triadic model where we're stabilizing physical health, mental health, and social health. So let's start with the top bullet because people like to go in order. It's pretty widely understood at this point, and you probably know these statistics better than I do, that COVID-19 has struck at Black and Brown communities in just a ravaging way. Black people are 50% more likely to die than white people from COVID-19. Of the 20 US counties where the infection rates are the highest, and this is January data, I'm sorry, 3 of those 20 counties are populated exclusively by American Indian people. And in California, where Latinx comprise only 39% of the population, Latinx people account for 55% of COVID-19 cases and 47% of COVID-19 deaths, a pretty wide disparity. But again, as we all know, health inequity is not a new concept. For many years, Black maternal mortality has been 3 times the rate of white maternal mortality. Hispanic women are 40% more likely to have cervical cancer and 20% more likely to die from cervical cancer than white women are. There are 11 infant deaths per 1,000 live births among Black Americans compared to a national average of almost half that. And American Indian and Alaska Native adults are 3 times more likely to have diabetes than whites and 2.5 times more likely to die from it. And these are just a small, really infinitesimal piece of the widespread health inequities we observe in this country. The disparity in death from COVID-19 by race and ethnicity is not dissipating. It continues on through the current moment. We are narrowing the curve slightly between white and Black deaths, but Native American deaths continue to climb at rates that outpace the death rate among whites. So how do these inequities arise? Is it just a feature of the color of my skin or of my job that drives these disparities? And you know, that's an absurd notion. We know in our bones, if not empirically, and we know it empirically, that these inequities are socially driven. This diagram on patient's right, since I can't tell right from left in any other way, is a pretty widely viewed diagram. And the pie can be sliced up in different ways. I think Karen Rhodes showed one yesterday that had slightly different proportions on it. But the important thing to know here is that almost all of the money in health goes to medical care. So essentially, we're receiving 10 cents on the dollar in return for overall health and well-being among individuals for every dollar we spend on medical care. Not very efficient. The other important thing to know here is that the orange segment of social and environmental factors is growing fast. So it's making incursions into individual behavior as we begin to understand structural violence better. For example, we've known for 40 years that cigarette smoking rates are affected by advertising and sponsorship by tobacco companies. So that's an individual behavior attribution for health and well-being, but it comes from being in an environment that's saturated with tobacco advertising. Similarly, we know that alcohol outlet density in a neighborhood drives drinking rates. It's not an association, it's a causality. And so that individual behavior would have been chalked up by Steve Schroeder when he wrote this paper to behavioral determinants of health, but it's really driven by the patient's environment. So these structural forces are inflating that orange segment and deflating the light blue segment. And social forces are actually even deflating the dark blue segment, the genetics piece. I don't know, I'd love to recommend a book to you all. Nadine Burke-Harris's The Deepest Well is, I hope some of you have read it, and I hope more of you will, is a description of her journey through the adverse childhood experiences world. and what to do about it, most importantly. But she describes in some detail the research on epigenetic drift associated with adverse childhood experience, mostly mediated through vulnerable telomeres in DNA, or in chromosomes, I guess. But much of what we have considered to be genetic determinism is now going to be attributed, I believe, to social and environmental factors. All this to say that as long as we concentrate only on the light blue, we're not going to get very far in improving the health and well-being of our communities. Only by focusing more in the orange and light blue will we really start to make incursions into people's suffering. How do we do that in the emergency department? Well, you will hear me talk about social determinants of health from time to time. It's a useful concept. I believe that it's a limited concept, and it brings us to talk about other nomenclature. Maggie Samuels-Kalo, Dr. Kalo at MGH, wrote, I think, a very clarifying paper a short time ago that helps us understand how this language works, and gives us, I think, a useful framework for understanding. So social determinants of health are often used in the context of adverse social determinants of health. But we have to remember that social determinants are valence-free, right? They can positively affect health, such as studies in resiliency, and they can negatively affect health. So if somebody faces an eviction, they may get rapidly rehoused, or they may end up chronically homeless. Both of those are social determinants. I think a more useful typology is thinking about the concepts, the dichotomous concepts of social risks and social needs within social determinants. Social risks are epidemiologic factors that help us to understand the social epidemiology of living conditions or of adverse social determinants. So these are useful from a scientific standpoint. They're useful to payers. There have been several papers now, for example, on the effect of adding social risk factors into payer mix algorithms so that, risk calculators, so that payers will understand the extra costs associated with caring for people with substantial social needs. And these really do affect reimbursement rates in models that have been published by a couple of groups. They also allow practitioners, clinicians, to incorporate social risks at the bedside, to understand that if somebody is carrying in with them, let me return to the alcohol outlet density one, a risk factor from their neighborhood that exposes them to excess risk in the emergency department, we can act on that as we shape our practice. Maybe not at the bedside, but to shape our practice. Social needs, on the other hand, are something that a patient might identify in a screening instrument on their way into the emergency department. These are particular social risks that this patient faces that expose them to a need that needs to be addressed in order to maintain or optimize health. And what understanding social needs does, in contrast, is help us at the bedside, provide targeted assistance. So that's, in my mind, a more useful nomenclature than social determinants. I also want to share something I learned from my student and mentor, Dr. Dennis Shea, who describes SEAL needs. because the concept of social, educational, environmental, and legal needs really incorporates the universe, for the most part, of things that we can do something about in the emergency department. And I find also to be a useful typology. So that's principle number one. Principle number two, we often hear from the not my job community that we're busy, we have lives to save, and I don't have time to add this to my already clamoring list of things to address at the bedside. And I want to say I hear you. I do. But just as we don't expect our emergency clinicians to take an undifferentiated patient with chest pain, make the diagnosis of AMI, perform the cardiac catheterization, do the rehab, and follow up the patient, nor do we expect the emergency clinician to identify somebody who's hungry, get that person connected to a food program, and follow up to make sure that their nutritional indices recover after feeding. So we do this by establishing relationships with trusted community partners who know how to do this work and who need our patience, frankly. We are a sorting system. The emergency department is a sorting system for high social needs populations. It's been demonstrated many times that social needs are concentrated in emergency department populations. So we invite our community partners into the emergency department, following the concept of in-reach as opposed to outreach. We know that paper referrals in some studies result in a 1 to 2% uptake rate at the back end. And we invite them into the emergency department for bedside advocacy and a warm handoff to a trusted community partner. They love it. We've done it for years, actually, in intimate partner violence. You may do it here. We've done it for a couple of years among survivors of human trafficking. We'll look at a paper in a few minutes that does it for food insecurity. And we're working on doing it for housing. So it is definitely doable, and it's definitely preferable to a paper referral. The third thing I want to keep in mind is that bias is everywhere, and we really have to be alert to it. I want to reproduce for you, much less eloquently than Dr. James did it, a talk that Thea James gave us at the first consensus conference in social EM, which was in Dallas 3 or 4 years ago. She asks us to imagine 2 patients, both of whom are clutching the sheets over their head and not wanting to participate in the H&P. And I know we've all seen these patients, but she describes the first patient as, she's there in the emergency department on the day of the Boston bombing, and people are, lying on gurneys in the hallways, traumatized and hard to approach. And not a single clinician working that day had trouble understanding intuitively how to provide trauma-informed care. Even if they hadn't been trained in it, they understood that these patients needed space, they needed a fresh approach to the bedside, and they were all willing to do it. In contrast, if you make that person huddling under the sheets with the, clenched in a fetal position, a young Black man handcuffed to the gurney with a police officer by their side, they get 1 approach, maybe 2, and then we go to the EMR and we type non-compliant with exam, uncooperative with exam, and that's it. And we may push on their abdomen and chest through the sheet and say fit for incarceration. We do not provide that young person who has undergone trauma, I think it's, you can't know exactly what that person has undergone, but you can give them the benefit of the doubt that they may have survived trauma equivalent or worse to what the Boston bombing survivors experienced, and yet is not given the same latitude to manifest their trauma in the emergency department, and is not treated with trauma-informed principles. So we identify a lot of social needs and social risks in the emergency department. There is a division in the field about whether we ought to be identifying things that we can't take care of. And I think that this is another thing that feeds into the not my job idea, which is that, I don't want to, I don't want to look in places and find things that are going to take my time when the person's not going to end up any better off. So the major charge of social EM is to develop tools for the clinician and the health system that make the right thing to do the easy thing to do. And there are many examples in the literature. I just picked this one because it's written by some friends of Dr. Killaroo's. In this paper, we describe a project where we opened a help desk for health-related social needs outside of the emergency department. We only had enough resources to run it for 2 days a week. And so we used that as a natural experiment to collect data on social needs from people who identified that they would like to use a desk like that. And we found that on intervention days, people were basically twice as likely to be connected to an agency that could address their need. The project worked great. We had the desk for many years. That we closed the physical desk during COVID, but it still persists as a referral program, which obviously doesn't work as well as I just said. But we have been able to get health advocates to the bedside for patients for years, and connect people to needed services. But what about the community partners piece? Well, the health advocates had a community partners piece a little bit in that we have medical legal partners involved in health advocates who, for example, if a health advocate writes a letter to a landlord saying you have to abate the mold in this person's apartment, it's driving them to the emergency department every month for asthma exacerbations, and then they get an eviction notice. Well, we now have medical legal partners who can meet that landlord in court, which is something they're not accustomed to, and forestall or eliminate the risk of eviction. But there also are a growing number of examples of emergency departments bringing community partners into the emergency department to address social needs. And one of the best examples of this happened just up the street. And I have to say that if any of the authors of this paper are here today, I apologize if I mangle it. I'm a big fan of this paper, so I hope you'll chime in and correct me if I get some of the interpretation wrong. But let's look at how this program did using our rubric to understand social EM. So this is a program that looked at a problem. So they identified a problem, which is that that kids are hungry. Kids who are families who typically rely on the schools to feed their children, feed their families during the school year, during the summer when they're not in school, they struggle. So the Department of Agriculture understands that, and they created a summer food service program to address that very issue. But only 20% of the meals available in the program were being used in Philadelphia at the time. So the emergency department investigator said, aha, we see kids all year round, not just in the winter. And so perhaps we could be a source of food for the summer food service program. So they had this aha moment, and what did they do? They went to a community partner that understood food insecurity in the community. And they, that community partner went essentially bed to bed in the emergency department to connect kids, but first to give them food, and then to connect them to the summer food service program. They provided them with a meal and a voucher to the program. And so how does this fit within our rubric? Well, they certainly looked upstream. They found that there was a high prevalence of hunger in their emergency department. In fact, in my emergency department, I was there for 15 years or so, maybe more, before I asked the question and discovered to my shock that 50% of the patients in our emergency department are food insecure. Their prevalence was 25%. How did they involve community partners? Well, this is a very useful study for that, because they provide a roadmap for how to engage with a community partner, for what the steps they had to take, and the sort of mechanistic view of how to do this. It's a wonderful model from that standpoint. And then how did they address bias? Well, by hiring people from the community to be these food liaisons in the emergency department. These are people who may have previously had to check the box that said they had no job experience, and now they have job experience. They have direct patient care experience to complement their lived experience of living in high social needs environments, and are on their way to careers in social or health services. So this is what makes an academic institution an anchor institution, investing in economic and job opportunity in their community. And we all have the ability to do that through our staffing models, but very few of us do. So this paper represents a winner on so many fronts. So how does COVID play into this? And I understand that I have dragged on quite a bit here, so I'm going to try to move it a little faster. But what I haven't mentioned COVID yet. So COVID hits, and what happens? What's the response from emergency medicine? Well, the first thing is that EMRA was really fast off the dime. I mean, if you look at this, in April, they were having colloquies about the impact of COVID on vulnerable populations, about disparities in COVID-19. They didn't aim low in their panelists. They have, I think you had Kelly Dorn here earlier this year. Bill Source is a Highland grad who understands social factors as well as anybody working today. They had the inimitable Thea James. Dr. James is the inaugural recipient of the Thea James Lifetime Achievement Award in Social Emergency Medicine from ASAP. And everybody on these panels really is a serious thinker and a great communicator about the importance of social factors in emergency care. So bravo to EMRA for stepping up so completely and quickly to help us untangle this. I have to say that in my mind, this typifies one of the other things that's really bright about social EM at this moment. And that is that, if you'll pardon the sort of generational dialectic, I really think that millennials have a grasp of the importance of social context in American life in a way that people of my era don't intuitively have. And it allows the next generation of investigators and agitators in social emergency medicine to have sort of a leg up, because they already understand it in a way that is much more complex and complete than the people than I do, you know, the people of my generation, including myself. How about programmatically? Well, this is I'm just going to use another paper from my home institution to illustrate this point. I was already at the Healthcare for the Homeless program at this point, so I was out of the emergency department, but they quickly observed that this pandemic was not universally distributed among the community in Oakland. And you can see that they had this submitted by June for April and May data. And so they worked very quickly to get this word out. And they wanted to communicate the fact that this disease seemed to be striking Black and brown communities in a much more severe way than white patients who used our emergency department. So, Latinx patients, for example, who were only a quarter of the people, the PUIs who were tested here, and this is when we were only testing PUIs, they accounted for a quarter of the people who were tested, but almost 60% of the positive tests. For a test positivity rate among Latinx patients of 40%. That sounded an alarm, but what I really want to focus on is what doing this study led to in our emergency department. So as they were doing this study, they realized that a substantial proportion of the patients who were being categorized as Latinx were actually indigenous people, Central American indigenous people, Maya people, who speak a language, mostly a language called Mam, which is a spoken language only. I don't think there's a written form of Mam, or any of the Maya dialects. And these patients were being categorized as Latinx because they maybe look Latinx, or because some of them speak Spanish as a second language. Some of them don't. But they were clearly being miscategorized, and they were not then able to be reached through the outreach programs that the hospital was establishing in response to the previous paper. So they went back and reviewed 1,500 of those tests that had been performed for the previous paper, and again, all among PUIs, and they found that 560 of those people had been identified as Latinx for their previous paper, 36% of the PUIs, so of that cohort. So they then went to the language field, which identified 25 of those 562 as Mam speaking, and that was great. But then they went and did a manual chart review and found another 50 of those 562 patients. 10% of them were actually Mam speaking, in addition to the 5% that had been identified from the language field. The overall test positivity rate in the study was 17%. In the non-Maya Latinx population in this cohort, this is not from the previous cohort, was 27%. You remember in the previous one, it was 60%. But the test positivity rate among the Maya people was 73%. So they clearly had a worrisome cluster. So what did they do? First of all, they identified this misclassification problem. If you misclassify people, you're never going to be able to communicate with them. And they identified this risk pocket, and then they came to the county, both the Department of Public Health and Alameda County Healthcare for the Homeless, and we built a collaborative response for outreach and education. And what is the aftermath? This is unpublished data from the authors, because I know them. And the rate among mom-speaking people in our emergency department has dropped down to 1% or so, in response to the coordinated response that they mounted. I just want to talk for a second about housing. The picture, one of the sort of central tenets of social emergency medicine is that housing is healthcare. And there is some evidence to support this. I know it's probably a concept that Dr. Dorn talked to you about. But in 2018, when the National Academy of Medicine brought experts together to study the question, they were unable to find sufficient evidence to support this notion. Now, we all know that absence of evidence is not the same as evidence of absence. So essentially, some of us took that as a signal that we just need more study here. So COVID-19 may have provided that opportunity. In March of 2020, Governor Newsom announced Project Room Key, which allowed the state to use mostly FEMA money, but other state and county funds to lease hotels that were disused at the time because tourism had fallen through the floor, and use them to house people experiencing homelessness and protect them from the pandemic. In Alameda County, we operated two separate models. One was an isolation and quarantine model, where people mostly from emergency departments, but also identified by street health outreach workers, for example, could be referred in and could undergo isolation or quarantine in that hotel under supervision to decompress the hospitals of people and the shelters. But the model that I want to focus on a little bit more was the Operation Safer Ground model. The first model we called Operation Comfort, the isolation and quarantine hotels. Operation Safer Ground, in contrast, was intended to remove people at high likelihood for severe disease should they get exposed to COVID, people who are elder and medically complex, from congregate environments, both shelters and street encampments, and to house them in hotels and keep them relatively, or help them stay relatively out of harm's way from the virus. It worked great. At its peak, we were housing 15% of the Alameda County homeless population. We had a very low number of positive tests among the Safer Ground cohort, and not a single COVID death. It was a remarkable experience. It's still going. It's undergone some changes with time and with the fluctuations in funding. I show this picture because that's Kay Lind in the front there, one of our valued faculty. Michael Terry is behind her at the table. These are people from our emergency department who came to the shelters with me to identify elder and medically fragile people who would be candidates for lifting to Operation Safer Ground. And in 1 week, we lifted 600 people from Alameda County shelters into the hotels, thanks to the Highland Emergency Department. There was one more point I wanted to make about Safer Ground, but it eludes me at the moment. So I just want to remind you that as the mom work shows and the earlier work from Highland shows, the emergency department is not just a surveillance site for medical trends. We can observe trends in social risks also from the emergency department, and we should. And lastly, that health disparities are not just inert facts. They're clues to look upstream at social and structural forces that point us to action. And I think that's all I have, and I'd be pleased to take questions. Thank you very much.
Well, thank you very much, Dr. Alter. That was great. Really appreciate it. Wonderful, wonderful talk. And hopefully everyone was really stimulated by that. And thanks for recognizing a number of our faculty who indeed have been very involved in sort of adjacent and highly related topics. If anyone has questions, perhaps we have a couple of minutes for questions. And while you're putting them in the chat thread, I just wanted to point out, Dr. Alter, I think you're aware of this, but for everyone to know that this is not just a keynote speech, but we actually recognize your work with an award. So normally we would have a little award presentation live. Sadly, our current circumstances do not allow that, but we will be mailing you the plaque. You're winning the Abigail and Gary Conrad Outstanding Contributions to Emergency Medicine Research Award. So you can, suitable for hanging on your wall and so forth. But we really want to acknowledge your significant work here in this area and leadership and inspiration as well. For those who don't know, Abigail and Gary Conrad are the grateful parents of Zachary Conrad. Zachary Conrad was a young man who had cardiac arrest that we were able to contribute to his life being saved and returning to have a lovely family. We've stayed in touch with him and his family. And he was very much, in a way, saved by emergency medicine research that developed many of the protocols here at Penn and elsewhere for cardiac arrest and post-cardiac arrest care. So in gratitude, they gave us funding to sort of endow this award. And so we'll be sending that to you. But I think the award also highlights the fact that emergency medicine research matters and it directly affects lives and helps contribute to saving lives. And in Dr. Alter's sort of use case, not only saves lives, but can save communities and contribute to our understanding of how to impact communities. So with that, I will, let's see, I'll stop my video and look to see about questions. It looks like a lot of folks have had kind thank yous to you, but let's see. Zach Mizell has a question, I think. Let me see here. When talking to leaders and others who believe that emergency departments are inefficient and expensive places to deliver all care, including preventive or social services, how do you respond? Are we competing for resources, partners with our friends in preventative, internal medicine, or pediatrics? Dr. Alter, any thoughts on that?
Well, I have thoughts about that, unsurprisingly. Number one, I just want to move away from the expensive part. It's expensive because we charge a lot. It's not an inherently expensive environment to provide care, especially when you look at marginal costs for non-acute visits. The last time this was carefully examined was in the 1990s, so we have to contextualize the cost a little bit. But when Bob Williams did his doctoral research, which he later published in the New England Journal, looking at the marginal cost of an emergency department visit, he used time and motion studies and inventory control methods to understand every piece that contributed to the visit. And he arrived at a figure of $24 in 1995 dollars for the marginal cost of a non-acute visit. So it's expensive because we charge a lot. It's not expensive because it's inherently expensive. That being said, I still believe in primary care, obviously. Ambulatory care is how we're going to get ourselves out of this, but we haven't fixed the system to a point that it works for folks yet because they're continuing to vote with their feet and present to the emergency department. How do we do it? Well, it doesn't have to be done on the costly territory that we occupy in a hospital. You can actually, discharge a patient or put them in an observation area that, let's say we create a social observational medicine, it's not in your obs ward, but it's an area where they the patients now become the, like as though we were discharging someone to physical therapy or something like that. They become the patient of another service of the hospital after discharge from the emergency department. So they don't weigh down your length of stay. They don't, occupy valuable real estate in the emergency department, but they're still receiving emergency care that we deemed was important and influenced their visit of the day in the same way that we may send somebody to get fitted for a cam walker with a fibular fracture or something like that. It doesn't have to happen in the emergency department, but it's part of their emergency care. As far as competing with our friends in pediatrics and preventive and internal medicine, I don't compete. I hope not to compete with anybody. When we started the Levitt Center, for example, I called the 6 or 7 people, including Karen Rhodes and Bob Lowe, who had written the papers that I'd wished I'd written, and asked them to join, to become our scientific advisory panel, because I didn't want to be viewed as competing with anyone. And I really do feel like there's enough work to be done that we can divvy this up and find ways to complement one another's strengths rather than viewing it as a zero-sum game.
Terrific. Thanks, Dr. Elter. And let me see, there's one other question, I think, well, a couple other questions, but we'll do our best to get to some of these. And actually, I would ask Dr. Elter, if you're able to stick around for a little while, maybe you can participate in some chat discussion as well and answer, because we're not going to get to all these questions today. But I think we'll reserve the honor for the last question before our 10 a.m. start to Kaitlina, who helped invite you and orchestrate your being here today. She just sort of, I think that's fitting that she gets the question. And the question is, what do you see as the biggest challenges in conducting research in social EM? And do you have advice for those pursuing work in this area?
Those are great questions. And, I haven't been that successful at it in terms of most of my work has been essentially self-funded. When you ask Garen Wintemute, who's probably the national authority on the emergency consequences of firearm ownership, during the period of the Dickey Amendment from 1997 to 2017, he estimates that he spent $1.5 million of his own money on his research. I think if you look at opportunity costs, probably, I haven't spent that much by any means, but a lot of this work has been done at night and on weekends because it's hard to fund. Today, that's really different. I think, Karen Rhodes is a counterexample. She's found ways of making her work attractive to funders and has been funded, really well funded for 25 years. So I think probably she's a better person to ask. And in fact, yesterday she touched on this, on how to package work in social EM that we can take from the learnings and apply more broadly in social EM, but is funded because it's the specific question is maybe not necessarily social EM. So for example, access is a key piece of the social EM puzzle. We know, for example, that homeless people use emergency services regardless of what kind of access we provide, because in Canada, people who are homeless use emergency services at 9 times the rate of matched controls, socioeconomically matched controls who are housed, and they have no barriers to care. So, but access to care is a good way in. You figure out a question to study where the specific case is beyond social EM, but the learnings that you draw from your research will help transform social EM. I guess that's my advice.
Thank you. And we really appreciate you joining us today. I'm from California. In a way, this is the bonus of virtual. We can have speakers from far and wide. We hope to visit with you one day in person, but you'll see from the chat thread, many people have been inspired by your talk, and we really appreciate it. And there are a few other questions in the chat thread. So if you're game, our faculty don't mind during their talks if you sort of throw out some answers or some thoughts. And I'd now like so fantastic. Well, thank you
for the day.
Fantastic. Love it. Love it. Well, thanks. So now we're going to turn to our next session of Research Day. And what we're going to do now is have each of the sort of research cores, if you will, or centers within our department, have an overview, a presentation from their leadership so that people can learn what we are all about at Penn Research. What do we do? And I think hopefully, especially for residents and students, this will be helpful. I also want to take a brief moment just to welcome all of the incoming Penn EM interns. I know many of you are on the call, and we're thrilled to have you here. This is a great preview for you to see what academic work is being done at Penn. I now turn it to Gina South, who will give our first presentation.
Hi, everyone. Harrison, thank you so much for that amazing talk. It was really inspiring. And I just wish we could have done it in person, but another year. So hi, everyone. My name is Gina South. I am the faculty director of the Urban Health Lab and am excited to talk to you a little bit about what we do. So I wanted to just start by acknowledging the ongoing terror that is experienced by many Black people in Black neighborhoods in this country at the hands of the police. This is a picture of Dante Wright, who was killed by the police on Sunday in Minnesota after being pulled over for expired car tags. He was 20 years old. This is a picture of him with his son. Reading about him in this case has been very hard for me, and I know for many others. And so I think it's important that we just acknowledge that that has happened. And although I don't do research on police violence and health, the root causes of that violence is actually the same as the root causes of much of the work that I do, and that is structural racism. Structural racism is defined as the confluence of deep historical, institutional, cultural, and ideological forces that unequally distribute resources and risks, and ultimately serve to advantage white individuals and disadvantage non-white individuals in this country. Structural racism is not something that individual people or even individual institutions choose or do not choose to practice. Rather, it's sort of baked into everything that we do. Actually, an example of structural racism is something that Dr. Alter talked about, which is funding. Thinking about what research questions get funded and what don't, who's making the decisions about funding. There is a well-known documented gap between Black investigators and white investigators in the getting NIH funding, and part of that is attributed to the study questions that people ask. Hopefully that is changing. The NIH just in the last month announced a new initiative to more specifically focus on racism and health for the first time. But that type of thing that I think we don't traditionally think of as structural racism, that's exactly what that is. In my work, structural racism is important because structural racism patterns neighborhood conditions by segregating people and unequally distributing neighborhood level resources and risks. This is a map of Philadelphia that shows the different colored dots represent different races and ethnicities. It doesn't even matter which dot represents what race or ethnicity. The point here that you can see is that Philadelphia is segregated by race. This is not unique to Philadelphia. Most neighborhoods and cities across the country are segregated in this way. This is, in fact, I would say that one of the defining features of American neighborhoods. And this is relevant because the most pressing health issues that are happening right now in April 2021 in Philadelphia and across the country are disproportionately impacting Black people and Black neighborhoods. And again, all of that is rooted in structural racism. This graph right here shows gun violence rates in Philadelphia with this dotted blue line showing the pandemic, the start of the stay-at-home order. Now, gun violence rates were too high before the pandemic, but they have surged to out of control levels since the pandemic. This, of course, this graph here shows COVID vaccine rates. We know, as Dr. Alter showed graphs, that COVID infection mortality rates are higher in Black and Brown communities, but vaccine rates are lower in Black and Brown communities, and that has to do with structural barriers. And then down here, this is a paper that Utsa Khatri, one of our fellows, led, looking at opioid overdose in Philadelphia, comparing post-pandemic to the period right before the pandemic started, and then the same time period a year ago. And what we found was, for the first time, the absolute number of Black individuals having either a fatal or non-fatal opioid overdose in Philadelphia was higher than for white individuals. All of this motivates the work that we do at the Urban Health Lab. We have three sort of core components, the first of which is partnering with communities. We can't do any of this work by ourselves inside of our ivory tower. We have to get out of the tower and partner with the people whose lives we're trying to impact. The second is building healthy neighborhoods. Much of the work I do has to do with actually building healthy neighborhoods, so the physical environment, but it's also about building healthy social environments as well. And then finally, creating evidence. We are a research lab, I'm a scientist, and we need to build the evidence base for these sort of pressing social and economic questions so that policymakers actually have the evidence they need to implement effective policy. This is part of our team. Nicole Thomas is the director. She just started last month. I'm incredibly thrilled to have her. Kenny Oyakami is a clinical research coordinator who's worked with me for several years. And Abby Dolan is the project manager for our CDC funded project, Sparrow, which is in collaboration with Zach Mizell. We have a strong focus on working with trainees of all levels. This is just a sample of current and recent past fellows, residents, and students who we have worked with. Mentoring I have benefited tremendously from strong mentorship in my career, and so giving that back in mentoring individuals is really important for everything we do. We have sort of 6 core areas that certainly overlap with each other of buckets of work that we focus on. I'll just tell you briefly about some of the work that we do in urban nature, which is something I feel very passionately about. Over the last 10 years, we have myself, my mentor, Charlie Brannis, John McDonald, collaborators like Keith Green at PHS, we have conducted a series of studies demonstrating the health benefits of making simple, structural, low-cost interventions to the neighborhood environment, such as vacant lot greening, on health. And so Philadelphia has 40,000 vacant lots that are often, like this picture up here, filled with trash, overgrown with unwanted vegetation and weeds. This intervention turns that space into a simple, clean and green space. And what we have shown is that this intervention is it leads to, I can say leads to, because this isn't a large randomized controlled trial, a reduction in gun violence, increased perception of people feeling safe, increased people reporting that they socialize with neighbors. That's connection between what you do to the physical environment does impact the social environment, and then decreased feelings of depression. Right now, we're just starting a study where we are building on that model to actually work with communities to turn those green spaces into actual mini park spaces. And finally, this is a recent op-ed I wrote in the Washington Post. And I love the title of this, which is why I put it up here. Ultimately, if we as a country want to demonstrate that Black lives matter, we have to invest in Black people and Black neighborhoods. And that has sort of become my rallying call around a lot of the work I do and a lot of the things that I talk about. If you want to get involved, we have weekly lab meetings on Wednesday from 3 to 4. You can email us, and please check out our website at urbanhealthlab.org. Thank you.
Thanks, Gina. That was terrific. We really appreciate that. We'll turn now to our next center leader, Dr. Kit Delgado, who'll be talking to us about his work and the Be Safer group. Kit, it's all yours.
You guys hear me okay?
Yep, sound quality is good.
And you see my slides?
Sure do.
Great. Hey, thanks, guys. And Gina's such a tough act to follow. She's been such an inspirational leader and doing amazing work. And Harrison, it's great to see you and great talk. I'm going to talk about our work in the Be Safer Lab, which stands for Behavioral Science and Analytics for Injury Reduction. Our mission is to apply data, behavioral science for trying to prevent the types of injuries and overdoses we see in the emergency department, as well as to also improve acute care. My daughter summarized kind of what I try to aim to do or aspire to do, which is to help people make better decisions. And I think the overall goal is, I think we know both in clinical practice as physicians what we want to do, but we often don't accomplish what we want to do, sort of the knowing versus doing gap. And then the same thing for patients who sustain injuries. And so this is our application of that. I'm going to highlight, like to highlight a lot of the mentees that and collaborators that have worked with us in this lab in 3 main topic areas. So the first main topic areas, we have a lot of fun with analyzing large health system as well as state and national data sets, administrative billing claims, as well as insurance claims, to help elucidate opportunities to improve emergency and trauma care, and just highlighting some folks that either are still at Penn or gone on to other places who've done work in our lab. So the first is Eleanor Kaufman. She's really just a superstar, and if you don't know her, you should follow her. She's one of our trauma surgeons, but started here in the Masters in Health Policy program, published a number of papers around trauma and firearm injury and violence. Had a recent paper in JAMA Internal Medicine, really documenting the epidemiology of firearm injuries in the US. Kaman Anides was a med student here, and we've looked at what happens when you adjust for race and poverty and how that affects quality measurement and emergency care. Edouard Coupé was a fellow here, and he's done work in violence and substance use, is now at Yale. Obviously, you guys know Austin. Laura Medford Davis is now faculty at Baylor. And Emily Earl Royal is a resident at Stanford right now. One of our major sources of funding for doing this kind of work is from PCORI. And we competed for this grant with a large multidisciplinary team involving several investigators who you recognize there at the bottom from our emergency department, but as well as people in the Center for Healthcare Innovation. As you know, with COVID, most patients that we see in the ER, actually we can discharge home, and most patients that are diagnosed as outpatients can be managed at home. And so the health system set up this program called COVID Watch, which it's easy to enroll. Patients get text messages twice a day asking how they're feeling, and if they're feeling worse, they get escalated to a nursing assessment within 30 minutes. And we offer this program free of charge to everyone. And there's been over 15,000 patients enrolled. Over half are Black and live in Philadelphia, and 1/3 don't even have a primary care doctor. There's some very exciting preliminary findings, which we're about to submit for publication this week, but showing that COVID Watch reduced mortality fairly substantially for patients who had not yet hit the emergency department. by getting patients to the ER on average 2 days faster and in better condition, and prevented people from dying at home. So that will be under review pretty soon. A second major area in our lab is around developing and testing health system interventions for promoting opioid stewardship for pain management, as well as facilitating the treatment of patients with OUD in the ER. Anish, who started off as a clinician scholar, has been really leading a lot of this work and recently published, I'll highlight this a little bit more, in JAMA Open, and this is in collaboration with several surgeons. Maggie Lowenstein is a general internist who's been working very closely with us and is doing a number of health system interventions. Austin's published in this area, as well as Edouard Coupé. You may recognize Mike Yokel. He was my mentee at Stanford and actually was the first person to get me into this work. He's a graduate of the Penn residency program, and Eric Blutinger did a nice residency project in this area. A lot of our work in this area is funded with a couple of contracts from the Food and Drug Administration around creating a scalable and patient-centered approach to right-sizing opioid prescribing through work led with Anish and Zarina Ali and Dan Lee, who are, Zarina and Dan are surgeons, and Hannah Lacko helps manage quality for the orthopedics group. We developed a text messaging platform that texts patients after surgery to find out how they're doing with pain and how many pills they have left over after surgery. And we recently published this in JAMA Open, but what this allows us to do is to create indication-specific guidelines for opioid prescribing that give surgeons the confidence that they can reduce excessive prescriptions, knowing that patients will be fine with managing their pain. And this is something that we're scaling up throughout the health system. Another major area of work is kind of, this goes along with what Harrison said before in terms of making the right thing to do, the easy thing to do. Now is the goal behind the CDC funded project where we want to create a warm handoff to treatment as the default option for patients with opioid use disorder. So you're probably aware that recently we implemented universal screening and triage for active opioid use, which then triggers nurses to talk with docs, and you may have seen some of these banners that pop up in the EMR to encourage evidence-based treatment. And so we're evaluating those outcomes now. And then lastly, this is where I've been getting more mentorship in career development, but in developing and testing interventions for preventing people from coming to the ER, and using distracted and alcohol impaired driving is really sort of important topic areas, but a way to apply this research. And I've benefited from the mentorship. Colleagues like Kate McDonald, Flora Winston, Scott Halpern, and Doug Weed. We have the last set of projects funded by the Department of Transportation and the NIH, where we've partnered with Progressive Insurance, and we've now done we've done 2 field experiments with over 4,000 customers, where we're using their insurance platform that prices their insurance based on how they drive, and manipulating different aspects of feedback and insurance discounts to reduce phone use while driving. And that's going to be in publication soon, showing that we are able to use behavioral science to improve people's driving habits. And I'm very excited about this new app that we have created using the same technology behind this Progressive app, where we can now enroll our own drivers across the country. This will be in the App Store in June. It's called Way to Drive, and this will open up the ability to do research across the country to further improve driving behaviors. I'd just like to acknowledge my really excellent staff: Jesse Hemmons, our project manager; Dina Abdelrahman, also a project manager; and Dina Chisholm, is one of our project managers. Evan Spencer is a research coordinator. Arya Zhang is our analyst, and our newly hired research scientist, Jeff Ebert, who's a social psychologist. So if you're interested in any of this work, we'd love to have you. Just email me. Thank you.
Terrific. Thanks so much, Kit. That was great. Our next center of research activity, the CECPR, Center for Emergency Care Policy and Research, will be presented by Zach Mizell. Dr. Mizell, we turn the floor to you.
Great. Can you see my screen?
Yep, we can see the screen and we can hear you.
Excellent. Okay. Well, I have in some ways the easiest job as the faculty director of the Center for Emergency Care Policy and Research, largely because we are an umbrella group that includes pretty much all the speakers and labs that you are going to hear about or have already heard about today. And we have such amazing, an amazing group of faculty and research that come together under the banner of CCPR, and they do the hardest work and are populated by some of the smartest and most thoughtful researchers, which includes this is an older picture, so it includes not only Kit and Raina and Gina and Fran and Jean Marie, but also Austin, Ari, and Anish. And hopefully others as we continue to develop. Basically, there's been a lot of talk today about Karen Rhodes, and I do want to acknowledge Karen. She's still actually part of our center, and she comes to virtually to some of our meetings. Karen, as many of you know, was faculty here for many years and founded the Center for Emergency Care Policy and Research. We developed our mission, I remember, I don't even know how many years ago now, at a small retreat on the New Jersey shore, where we kind of brainstormed and thought about what this center would do and how it would continue to develop the research that is, I think, more important than ever related to health services. So for those of you who don't know or may not totally understand or what health services research is, and I've been doing this for almost 15 years, and I'm still sometimes not sure I know what health services research is or what the scope of it is. It's really broadly defined as the science or the study of healthcare delivery or delivery science. And that includes economics, it includes health policy, it includes quality and safety, and importantly, it includes inequality and health equity and disparities. So it's a lot of stuff, but I do want to make sure that people understand that this really is different or distinguished from sort of classical clinical research where you're testing maybe drugs or devices, etc. And it is also different than basic science or bench research. So it's a field of science that is really particularly strong at Penn, and our emergency group has probably some of the most accomplished health services researchers in the country. And we come together under the banner of CCPR to continue to further our mission. So I want to basically walk you guys through what our website demonstrates, and I want everyone to pay attention to our URL, which is Penn CCPR, and please explore it on your own and follow us on Twitter, which is at Penn CCPR, because there's a ton of exciting stuff happening all the time. So I'm just gonna kind of walk you through it. So this is, let's start with people here. I hope it's not being slow because this was, there we go. So we have core faculty who I mentioned, as well as adjunct faculty and it's adjunct faculty from outside our department. And I think it's one of the things that makes CECPR great. The web is being a little bit slow, so I apologize here. But our core faculty I mentioned, as well as adjunct faculty from general internal medicine, as well as pediatrics, as well as Wharton, as well as outside of the School of Medicine. We have fellows and student researchers. And I think that's one of the things that makes our center particularly strong. Every year we host one or more medical students who are taking a year out between their 3rd and 4th year of med school. And they come and they partner with our faculty to conduct research in health services that relates to emergency care. And so some of you may know our current fellow, that's Eden Engel-Rebitzer. She'll be presenting some research later today. Superstar PSOM med student who's spending the year with us and has already won some awards related to her work with our group. Last year we had Max Jordan Ngumini Tiako, who is a Yale med student who spent the year working with Gina South and I. And prior to that, we had Dan Stokes, another Penn Med student who has been doing amazing work with Raina Merchant as well. Prior to that, we've had a series of med students, including our very own Rachel Graves, the resident who spent a year when she was a Penn Med student working with us and doing some highly impactful research. I am going to move on because for whatever reason, the people tab seems to be a little slow, but some of these projects you have just heard about, and I'm going to skim through quickly because they are represented by other speakers today. Some of Kit's work related to risky driving, Raina Merchant's work related to Twitter and cardiovascular health, Austin's work related to alternatives to hospitalization. Some of the work that I've been doing focused on opioid risk reduction in the emergency department and communication of evidence. Gina's work, again, which you've just heard about and is ongoing. Many of these projects, if not all of them, relate to partnerships between our faculty. And I think that's another thing that makes CECPR so strong, is that we are truly collaborative in so many ways. And we're really eager and excited to bring more people into the fold. So this isn't just about faculty, this is about students and residents if they want to join us. We have regular research meetings as well as opportunities that come along, which include connecting folks with grants, as well as other additional resources, including some of these year-out and sometimes summer opportunities for students to come work and do research with us. The big ticket topics that we've focused on recently have been in the areas of built environment, structural racism, substance use and opioid use disorder, as well as injury that Kit described some of, as well as knowledge translation and health care communication, focusing on patients, providers, as well as policymakers. And we've been able to take advantage of our connections with a center that many of you may not know about, called the Leonard Davis Institute of Health Economics, which is a center that spans multiple schools, is located on the other side of Spruce Street next to the Wharton School, and is run by our colleague Rachel Werner in General Internal Medicine, which has a real focus on how we actually translate research into action through policy or through implementation. And we partner with LDI across a variety of projects. And we've, I think, been able to really take advantage of that that partnership to really focus both our research as well as our dissemination efforts on being able to make our research and our work actually applicable, as opposed to just publishing it in our, in our siloed journals or in keeping it within the department. So I'm going to stop there. Please follow us on social media. I do want to make a special, say a special thank you to our staff, which is primarily supported through the amazing and hard work of Abby Dolan, who is a project manager for the projects that one of the projects that Gina mentioned earlier, which is Sparrow, that I worked on with her, but is also really our go-to person for all things CPR. So if you haven't met Abby, she is awesome and is somebody who's around and can connect you with so much of the work that we are doing with Penn CPR. So I will stop there and unshare my screen, and I'm happy to talk to anyone anytime about our work.
Thanks so much, Zach. That was terrific. And yeah, and I should point out actually that if folks have questions for some of the presenters today, feel free to use the chat thread. We can keep conversation going. So if students or others want to learn from Zach or Gina or Kit or others, reach out using this tool. All right, next will be Dr. Raina Merchant, who I've known for, 20 plus years, back to our Chicago days. Raina will be presenting on the Center for Digital Health. Raina, the floor is yours.
Thanks so much, Ben. Can you see my slides and hear me? The only person I see is Zach.
Yes,
so
yes.
Yes.
Okay, great. So thanks so much to Ben's son and to Ben Abella and the entire committee who brought together this amazing research day. It was such a pleasure to hear from our grand round speaker, our guest speaker, as well as from all of my colleagues and the amazing work that they're doing. I'm going to share some work about the Penn Medicine Center for Digital Health, which I direct at Penn Medicine. Our focus here is we are committed to working on problems that lie at the intersection of healthcare, technology, and society. And we hope to lead and support initiatives that will advance science and improve systems and patient and public engagement. Three of our sort of focuses are on looking from data to insights. One of our key areas of work has been on a area that we call social mediomics, which we consider the study of collective characterization and quantification of social media and other digital data that tell us a lot about our health and our healthcare. We have been building a registry of this data over the past 7 or 8 years, where we are asking patients who are willing to participate in research and willing to, and who say that they use these digital sources to share this information with us, plus access to their health record data. And across multiple settings, we've had more than 86% of individuals share. We have data from more than 6,000 Penn Medicine patients with more than 50 million data points. That's focusing on social media, but we've asked people to share a range of other data sources. You'll see on this graph, the blue represents people willing to donate right now. So people would give us their Pandora, their Spotify, their voting history, information about their genetic data, and even their tax records. And then the orange represents this concept of donating your data. I bequeath. I'm not going to leave Penn Medicine $100 million, but I will give them access to all of my digital data. And so here in the orange bars, we see that people are more willing to share their data, potentially after death, that would allow us to understand more about their health and the healthcare choices that they make. Here are a list of several of the different investigations that we have ongoing that look at data that is merged from both health records and a series of data sources, including Google searches and other information in mental health, cardiovascular care, loneliness, social isolation, diet, lifestyle, and women's health. And then we also have a series of projects that look at mining online reviews. And this is some work that Zach Meisel and Anish Agarwal and I have a R21 to support. I like this picture from the New York Times where they talked about some of our work. Died, you didn't die, but were you satisfied with the care? And here we have a series of projects that look at online reviews to better understand healthcare quality and the things that matter most to patients and their experience. We've looked across hospitals, ER, urgent care, substance use disorder treatment facilities, mental health, and nursing homes. I've bolded at the bottom that this work has been driven and supported by med students, fellows, and now faculty in our department. Austin Kalaru, Rachel Graves, who's a resident, Anish Agarwal, and others have been leads in pushing much of this work forward. We also have work in the bucket of to action. Our center collaborates and sits within the Center for Healthcare Innovation to do a series of projects where we outreach to individuals across the health system for input on projects that they want to do with our center and the Innovation Center. Kit and others have mentioned this work. This is a picture of Iris at the vaccine clinic and the work that she has been doing there and increasing vaccination in surrounding communities. Here we partner and identify teams, provide funding, and then provide a series of individuals to work on grants that will then be presented at a broader advisory board. This is just a list of some of the projects we supported in 2018 in dermatology, in our department, in women's health, and in internal medicine. And then in 2019, a focus on cancer care, looking at using digital data to identify early signs of toxicity, to increase referral and early identification of patients at risk for bladder cancer. And then some work led by Kat Lee, looking at post-op care in plastic surgery. And then some of the work in Action to Spread, I just wanted to highlight two total rock stars, Kat Lee and some of the work that she's done that has really spread across the health system with High Five, and then work by Anish Agarwal across several departments looking at tracking patient and provider experience. I also want to acknowledge how our center has been responsive in 2020 to the dual pandemics that are happening of both COVID and racism. We've had several initiatives focused on COVID, a Penn Med with You platform, which was a texting platform to connect with patients in our emergency department and check on their well-being and provide them with access to resources like where people could get free meals, where they can do online yoga, online childcare sources, and others. And then a social media map, which we developed and several health departments are using. This is developed by Sharath Guntuku and our team, where we looked at what people were posting online and trying to evaluate how that was changing over time. We were able to identify people talking online about several symptoms related to COVID before they were posted as official COVID-related symptoms by the CDC. And then we looked across states and looking at terms of mental health, loneliness, anxiety, and signs of well-being and how that has been changing across the pandemic. Another initiative which our team has been spearheading is the Bold Solutions, which is focused on dismantling racism and advancing health. And the focus here is on science and action for Black health. The motivation for this work comes from long-standing commitment to health equity, and again, the confluence of events in 2020, the global pandemic, and the brutal killings of George Floyd and other Americans. We call this Bold Solutions because we recognize that working in this area, these are big, entrenched, multifaceted problems which require bold solutions to impact change. The focus really here is on using science and action to dismantle structures and behaviors and social norms that create and sustain racism. This is a picture of several of the members of our team. Again, this is an early initiative, so these are just a group of us, including Gina South, who have been spearheading several projects in this space. Some thought leadership from our team. This is work again by Gina South and Paris Butler in plastic surgery, looking at building a culture of anti-racism in healthcare, and then some work, a viewpoint in JAMA by Gina South and I, looking at the role of public health organizations can take in learning from social movements to advance accurate messaging. We've also, our team has been promoting science and scientists to study and advance research. We've partnered with LDI, which Zach Mizell mentioned, to support a call for proposals that would look at research on the effects of systemic racism. These are some of the short and long-term BOLD initiatives that we are considering and that the BOLD Solutions team has been working on. We received funding from IBC to look at a regional health equity initiative that we're working on across Philadelphia with CHOP, Temple, and the city, and several other areas of focus. I wanted to end here with this picture of Utsa and Gina and Kat. This is not my work. This is not the work of the Center for Digital Health, but I thought really important to highlight. And the work that they've been doing at Mercy with Penn Medicine and in the community to focus on increasing vaccine uptake in Black and Brown communities. This is sort of the perfect intersection of work that uses low touch digital tools, that uses a lot of the work that Kit talked about, that builds on health services research that Zach Mizell talked about, but really important work that's coming out of our department that I just wanted to add at the end. This is a screenshot for the how you work with us. And so there's a couple, we have office hours and other ways that you can connect with our team and others across the Center for Healthcare Innovation. Thank you so much.
Thanks so much, Raina. That was terrific. And I think I'll just take a minute to highlight, and to all the folks listening, note how all of our speakers have had several recurring themes, one of which is our engagement across the health system and across Penn and across the communities. I think it's actually probably a theme set by our keynote speaker as well. One of the things I'm proudest about our research faculty and research groups at Penn Emergency Medicine is we're not insular. We don't stay within our walls, and we interact broadly and really are leaders. And I couldn't be more proud of all of our faculty. So with that, now I'll talk about the Center for Resuscitation Science. And let me see if I can share my slides with you guys here. Okay, can everybody see my slides?
Yep.
Okay, going into presentation mode. Hold on, it's taking a second. All right, so hopefully you can all see this. So I'm here wearing a couple of hats. I'm vice chair and one of the organizers for today's events, but I also lead a center at Penn Emergency Medicine called the Center for Resuscitation Science. So in a little bit of time, I'd like to share with you what we do and some of the aspects of the center. You can certainly check us out on our website here, showing some of our project work and other things, but the Center for Resuscitation Science, like many of the groups that have presented today, we're across the entire Penn campus. We have faculty members at CHOP, we have faculty members at the School of Nursing, and we've hosted visiting scholars from around the world as well. So this is just a screen grab. And actually, most of these folks are still at Penn and still active with the center in some fashion, which has really been a terrific collaborative effort. We have faculty in neurology, faculty in critical care, and so forth. So it's a really broad group. We also have a lot of connections with NIH and national projects pertaining to resuscitation science. This is a large NIH-funded project called IceCap, looking at the dose of post-arrest targeted temperature management. Some of you may have received phone calls from me or others on my team after you've resuscitated somebody in the ER at Hupp or Presby. We're involved in this study looking at cooling after cardiac arrest and have a number of interactions with the Siren network. One of the things that our team at the center leads is something called the TTM Academy. This is actually an educational effort, not just research, because we really do believe that part of our role is clinical interface and helping train clinicians. And so we run a funded program on the education of healthcare providers in post-arrest care techniques. And we have a pretty robust educational program, including live video courses. Our last one was on March 19th. We had 220 people participate from around the world it was a workshop on how to provide better post-arrest care. And we're going to continue to do those programs. We also have an active podcast series. And this is a screenshot from Apple Podcasts. Our most recent podcast was an interview with the wife of someone I know many of you know, the famous Dr. Glaukomenflecken. He's a bit of a Twitter star. His wife provided CPR on him. He had a cardiac arrest, and he's been very public about this on Twitter. And our podcast 23 is an interview with the wife of Dr. Glaukomenflecken, Kristen Flannery. She's terrific. And you can certainly check them out on iTunes, and they're free. And we continue to roll these out as part of our TTM educational efforts. One of the things I'm actually proudest of at the center is some of our community work. This is something called the Mobile CPR Project, a funded group that goes out in the community to train CPR. Now, COVID has hit us pretty hard. People can't really get together for CPR training. We look forward to a return to full activity. But if you check out our website, we have a lot of content around CPR and some of our survivors. This here is one of my longtime besties, really, in the cardiac arrest world. This is Brenda Halliburton, who's a cardiac arrest survivor and a longtime friend, and she's helped us with this project as well. To show you some of our recent publications, work from one of our fellows, Oscar Mitchell, in hospital cardiac arrest related to COVID. Other work shown here, work from John Greenwood, just to show that we're not all about cardiac arrest. We do work in shock as well. These are some other recent papers, and I'd highlight also the work of Dr. Felipe Teran. Sadly, Felipe is leaving us this summer for a fantastic position at Cornell in New York, but he's certainly led huge efforts at the Center for the use of TEE during cardiac arrest. We also do a lot of work with the American Heart Association, and I highlight here a survivorship statement that members of our team were involved in at the AHA. We've also done some work in COVID. Just to highlight here, many of you in Penn were involved, perhaps as subjects, in a study looking at using hydroxychloroquine as prophylaxis. And as you know, we were one of the first groups to show that hydroxychloroquine is not effective at preventing COVID, which was an important addition, I think, to de-emphasizing some of these pharmaceuticals that really are not effective. I show you here two of the study team members just because I love this photograph, Eliana Jelkovsky and Barbara Biney. They've been coordinators with the emergency medicine department, but also were very instrumental in this COVID randomized trial for hydroxychloroquine, and we're very proud of their involvement in that. So this is a shot of our team out at a training. Zachary Conrad, who I mentioned, his parents helped support the award for this day. That is Zachary Conrad on the far left with the reddish hair. He's a cardiac arrest survivor, and that's him sitting next to his wife, who's actually a gastroenterologist at CHOP. And I show you here some team members, Jaldi Patel and Nabil Abdulhai and others doing a CPR training at 30th Street Station. We've also been involved in a lot of community work, and this is a photograph from just yesterday where we are doing free COVID testing in the Kensington area. And I show you here, you can't see so well, but Rachel McFadden, Nabil Abdulhai are shown there, as is Tony Davila, who's our laboratory manager who does a lot of COVID PCR testing with our group as well. So with that, I will close. Thanks very much. I show you some of the names of our coordinators. We also work very closely with medical students. Andrew Helber, David Helfer, Shar Tish, and Isabel Mullen have all been involved in projects. And we're actually submitting soon an important paper in post-arrest care that David Helfer will be the lead author, so we're excited about that. As always, a huge thanks to some people who really keep us in line: Eileen McDonald, Libby Moore, Karen Moore, and Suzanne Rizzio, who are our superb research staff at Penn EM. We really couldn't do any of this without them. And if you want to follow us on Twitter, there's 4 Twitter suggestions for you there in some aspects of the center's work. And with that, I will stop. Let me stop sharing my screen. Terrific. And with that, I will turn to our last of our center presenters, Jean-Marie Perron. Jean-Marie, if you are on, you can now join and tell us about your work.
Great. Thanks, Ben, and thanks for having me, and thanks to Harrison for a great talk. Long time no see. So I want to talk about the Center for Addiction Medicine and Policy. We are a new center at Penn Medicine, founded just last year, and founded on, next slide, Ben. Founded on the principle that we weren't really providing enough addiction care in the opioid use disorder crisis in Philadelphia. And if you look to, our resources around cancer, I often said that if your child was diagnosed with lymphoma, you would have a hard time figuring out which of the amazing lymphoma specialists we have at Penn who could provide, current care. But that same paradigm is not available for substance use disorder care, or at least it wasn't a couple of years ago. So our real mission is to address this continuing escalation in opioid overdose deaths, because there are some paradigms that are kind of unique in that we do have medications, but they are not getting to the people who need them. Next slide, please. So we have very effective evidence-based medications that aren't being used for various reasons. There are shortages of prescribers, patient misperceptions, stigma, high barriers based on insurance and policies, and the concept that addiction is a moral failing. Next slide, please. So the center was really founded on the idea that we would improve clinical practice, expand education, and disseminate research to mitigate harms from substance use. And even 18 months into this, I think we are at least scratching the surface of our goals. We are not a department or division. There is really no presence of addiction medicine formally at Penn. So we don't really have a house or department to live in. So we really need to coalesce all the different silos of people that are doing this work. And really my background is primarily as a clinician educator. I wasn't particularly a researcher, but obviously research is important, and that's why I've collaborated with all the people you've already heard about. Next slide, please. Lots of people doing work in this space in our department, but one effort led by Dan Stokes, who was the CECPR fellow, one of the two last year, wonderful, wonderful student. He took it on himself to study this gap in prescribers by looking at how medical students could get involved with training. And he evaluated 2 different pathways that could be integrated into medical school curriculum. And this was published in Academic Medicine just about 6 or 8 weeks ago. Next slide, please. What's so impactful about this is that it started a dialogue with our medical school about how we actually could integrate this. And now we have a plan with med school leadership to integrate buprenorphine prescriber education into the first year of med school curriculum, as well as extending that training to house officers and tracking credentialing of ex-waivered providers. So this is a big part of the foundation of what's needed to have prescriber readiness for buprenorphine delivery. Next slide, please. Another resident and pharmacist in our department, Amanda Deutsch and David, worked together a couple of years ago when we had an opioid shortage to look at the natural experiment of how that impacted patient care. And really the upshot of looking at before, during, and after the shortage was that because we had a shortage of hydromorphone, patients wouldn't be able to get hydromorphone unless we called down to the pharmacy. So that delay sort of naturally occurred, and providers would offer acetaminophen and ibuprofen if available and appropriate. And what we found was that a large number of patients did not get opioids and really were satisfied with their first round of non-opioid care. A small percentage of patients still needed opioids, and the MME or amount of opioids that they got did not change. So we really decreased the breadth of opioid prescribing and just, but didn't change the amount for patients who still really needed it. Next slide. So that's just coming out. It's accepted in proof. And that's been my pleasure to work with Rachel Graves since she was a CECPR fellow. She is a 3rd-year resident in our program, has done wonderful work with almost all of us on this talk today. But last year, in conjunction with a 4th-year medical student scholarly pursuit project, Megan Chenworth, looked at methadone and Suboxone mentions on Twitter. I should mention we have a collaboration with a colleague at Emory in a bioinformatics lab there, also looking at social media specifically for substance use disorders. So Rachel has these 2 projects, one in pre-submission and several projects that she's working on, including one looking at a stigma reduction initiative that we did in the med school and her evaluation of that process. Next slide, please. And then we do have a very large funded research study funded by NIDA looking at a randomized control trial between injectable buprenorphine, a new investigational drug, a 7-day formulation of buprenorphine that patients get, versus usual care with sublingual buprenorphine. And so this is our study team for this, and we've done really well. We've completed enrollment in one of our 2 studies, and we're now working on the RCT. And a shout out to Harrison's colleague, Andrew Herring, who is my co-lead, co-investigator out at Highland, who's also developed really an exemplary program in emergency department treatment of opioid use disorder. Next slide. So Rachel McFadden, who is our wonderful nurse champion for a lot of these issues, is working on a stigma reduction initiative in the hospital, focusing on person-first language. That's the poster on the left. And then our research coordinator team, Brittany, Alex, and Nicole, have come up with this harm reduction resource that we hope to integrate into our discharge instructions for patients with opioid use disorder, along with the leadership of Kit and Maggie on a CDC-funded screening process that we're working on. Next slide, please. We also have a partnership with NIDA to disseminate information to our West Philadelphia community about the rising deaths along with opioids due to fentanyl contamination of cocaine or just fentanyl use in pressed pills. So this is something that we're trying to get the word out that you could be prepared for an overdose even if you are not a patient with opioid use disorder, distributing naloxone and fentanyl test strips to that community, along with information for how to mitigate the harms and risks of substance use in this era. Next slide. So I'll close with, next slide, Ben. Our website has a lot of resources. We are really trying to build community across the many disciplines that are doing this work. On the left there is a Narcan Story Slam that we hosted last year, which was really to get people involved in carrying Narcan and sharing their amazing stories of resuscitation. And then we have an addiction medicine interest group in the med school, because this is such a area that people are of great interest in early in their training, and as you saw from lots of the efforts across our research endeavors. And then we hosted a Recovery Month book club. That's Liz Moore, the author of a wonderful book called Long Bright River. Next slide. If you go to our website, we have multiple events, including our speaker series that you can find under news, policy, and events, as well as if you look at the education tab, we have everything about getting your X waiver, how to post your X waiver to the SAMHSA website and upload it, as well as the all important challenge of e-prescribing buprenorphine, which is really a cumbersome process. So under education, you can scroll down and find all of that information. Next slide. Yep. So this is how you can contact us. And we'd love to hear from you. We are excited about our cross-disciplinary and interdepartmental work in the institution, and excited to form collaborations and mentorships as needed. So thank you.
Thank you, Jean Marie. That is fantastic. And I just got to say, it's really overwhelming to me, and hopefully you get a sense of this, just the range of work and the energy that our research faculty, staff, coordinators, fellows, students, nurses bring to the table for all this work. It's inspiring. With that, maybe we'll take a little break. Everyone could use a little stretch break perhaps, and biology break. So I would ask Nabil if you can put up the screensaver slides with our sponsors information and some other content. We'll reconvene in just 3 or 4 minutes, and we'll have our abstract presentations at that time. So thanks, everybody. Little stretch break. We'll come back in 3 or 4 minutes. Okay, hopefully everyone took a little moment to stretch or get a glass of water or do whatever they need to do. We'll now return to our research day activities. And so in this next hour and a half, and you know, we may bleed over a little bit, we'll see how it goes. A lot of speakers, so we'll so far, and I want to actually congratulate Nabil and Jaldi for doing a terrific job being stage managers behind the scenes for the Zoom program today. So thank you guys. Our first speaker is going to be Lindsay Chippendale. So Lindsay, hopefully you are available and can share your slides, and we'll have 6-minute talks and then a chance for questions. So please do put questions for our speakers in the chat thread for these original science presentations. Lindsay, I will turn it over to you.
Thank you. Can you guys see my screen and hear me all right?
Yep, we can hear you and see you.
All right, I'll go ahead and get started. So good morning, everyone. My name is Lindsay. I am a first-year pharmacy resident at HUB. And for the project that I'll be discussing today is titled The Assessment of Post-Intubation Sedation and Analgesia Among Patients Receiving Rocuronium for Rapid Sequence Intubation in the Emergency Department. So during rapid sequence intubation, an induction agent such as etomidate is typically given right before administration of the paralytic, in this case rocuronium. So the yellow in this picture represents the duration of action for the medications, and the blue indicates a potential for patients to be paralyzed without adequate sedation if the post-intubation sedation is not provided promptly. So as you can see, when using etomidate with rocuronium, the duration of action of etomidate is shorter than rocuronium's, indicating the need for post-intubation sedation in a timely manner. For our study, we completed a retrospective observational study in patients that received rocuronium for RSI in HUB's emergency department between September of 2018 to February of 2020. Including 100 patients. With the inclusion criteria, we included patients that received rocuronium in the emergency department for RSI and remained in the emergency department for 120 minutes post-intubation. For exclusion criteria, we did exclude protected populations, intubation by difficult airway response team, nasotracheal intubations, as well as some other indications where patients may be receiving different pharmacologic therapy than what is standard for RSI. For our primary outcome, we looked at initiation of timely post-intubation, sedation, and analgesia separately in patients receiving rocuronium for rapid sequence intubation. So to further define that timely post-intubation sedation, that really just means administration of sedation and analgesia within particular time periods after the administration of the induction agent. And these timeframes that we came up with are based on the duration of action for each individual induction agent. And of note, time to administration of sedation and analgesia was assessed separately. For secondary outcomes, we looked at different trends of sedative and analgesia dosing throughout 180 minutes post-intubation. And then all of our outcomes thus far have been primarily analyzed and presented and will be presented using descriptive statistics. In total, we started with 193 patients that were ordered rocuronium in the emergency department from September of 2019 to February 2020. On the right-hand side, I've listed the patients that were excluded. The majority of patients that were excluded were mainly due to leaving the emergency department prior to that 120-minute time point. In total, we did end up including 100 patients within the final analysis. For baseline characteristics, the mean age of the group was around 61 years old, and the population was about 53% male and 47% female. The mean, taking a closer look at mean GCS, which was 12, and the mean MAP, most proximal to intubation, was 93. And then looking at the main indications for intubation, the two most common indications were respiratory failure at 39% and airway protection at 57%. Looking at these groups of baseline characteristics indicates that the majority of the population was hemodynamically stable prior to intubation and showing signs of awareness to be able to and likely to require sedation and analgesia for intubation. For the primary outcome, on the left-hand side, we have post-intubation meeting timely criteria, which resulted in 58% of patients not meeting the timely criteria for sedation. And then on the right-hand side, we have post-intubation analgesia, which resulted in 56% of patients not meeting that timely criteria, therefore increasing the risk for aware paralysis for these patients. These graphs represent the median continuous infusion rates at time points throughout 180 minutes post-paralytic administration. On the left-hand side, we have the fentanyl median infusion rates, which, as you can see, there's an increase from time point 60 to time point 90, and as well as looking at the initial rate of 50 to the 180-minute rate of 100, that rate has doubled from beginning to 180 minutes. That red dotted line is at the 60-minute mark, just to indicate that's about the time where the rocuronium would be wearing off, since its duration of action can last for about an hour. This indicates that analgesia continuous infusions were increased once the rocuronium was no longer active. And then on the right-hand side is the median infusion rates for propofol, where you can see consistently stayed at 20 mics per kg per min throughout the 180-minute time period. For major limitations, this was a retrospective chart review, and we did utilize surrogate outcomes. For main discussions and conclusions, greater than 50% of our patients did not receive timely sedation and analgesia, and therefore we should try and place additional focus to ensure that timely initiation of sedation and analgesia to help prevent aware paralysis for patients that are receiving rocuronium for RSI and the ED. And then our observed increase in median continuous infusion rates of analgesia over time. So after that 60-minute time point, where you would have a lower RAS score, suggests that patients are not receiving sufficient doses of sedation and analgesia to provide that RAS score of -5 when the rocuronium is acting during paralysis. And so for future directions, we are currently in the works of creating a multivariable risk factor analysis. And this is focusing on initiation of appropriate sedation and analgesia, and we'll be looking at individual factors as well as multiple risk factors combined as well. And then we will plan on bringing these results to the emergency medicine clinical leadership to discuss opportunities to improve timely initiation and to optimize post-intubation dosing. And I would just like to take a second to thank my preceptors for all of their hard work and help with this project throughout the year. And with that, I thank you all for having me present, and I will answer any questions that you may have.
Thank you. That was terrific. Any questions on the chat thread? And perhaps while we're waiting for questions, I might just ask a question that isn't actually focused specifically on your research, but I think helpful for the larger group to hear. You know, the addition of pharmacy resources, pharmacy staff, pharmacy experts like yourself in emergency care has been hugely helpful and a wonderful addition to our team. Can you tell us a little bit about this residency program for pharmacy students and what that means?
Yeah, sure. So after a pharmacy student graduates from pharmacy school, they can go on to additional postgraduate training. So we have a PGY1 and a potential PGY2s for some people as well. So a PGY1 is a year's program where we spend about 1 month in different areas throughout the year. And it's really just like a typically hospital-based, but general, where we go to different areas of the hospital and work in that department. So right now I'm in an anticoagulation clinic, and that's what I'm doing for the month of April. And last month I was in the COVID ICU. So it just depends, but it's a good learning experience. And then you can specialize in a second year, but it's not mandatory.
Terrific, because folks may not be aware that these programs exist, and I think it's a fantastic training ground for folks who want to focus on emergency pharmacy work. And we hope you stay with us and help us out in the emergency department. And this is great work. Folks, if you have questions for any of the abstract presenters today, feel free to put them in the chat at any point. Lindsay, I'm sure you'll stick around for a little while and hopefully answer questions. So thank you very much. Our next abstract presenter is Eden Engel-Ribitzer. Eden was referenced a little bit in Zach Meisel's presentation. She's been a CPR fellow. Eden, are you available to share your slides?
Dr. Bella, I think I'm switching places with Eden.
Oh, I am so sorry. That is right. And I forgot to mention that in all the excitement of the day. So Rachel and Eden have switched places, right? Let me make sure I'm getting this right. Yes, Rachel Wu is going to be presenting next. There we go. So Rachel, thanks and sorry for that. Go ahead and present your work.
Thank you so much. Sorry for the switch, everyone. So my name is Rachel Wu, and I'm an undergraduate at Penn in the College of Arts and Sciences. And today I'm going to be speaking to you about the evaluation, management, and disposition of abdominal pain in older adults presenting to the emergency department. This was in collaboration with a very large team at Penn. And I'd like to thank Dr. Ari Friedman, who kind of spearheaded this effort. So why older adults and why abdominal pain? So older adults, those 65 years old and older, in 2017 were 15.8% of the population, and yet they were 20% of all emergency department visits and 36% of hospitalizations. Abdominal pain is the #1 chief complaint among older adults, and it's been highlighted in the research as a high-risk condition. So one study found that 5.3% of abdominal pain patients died within 60 days, and an additional 8.3% left the hospital with a new chronic disability. The top cause of death for discharged Medicare patients with an abdominal pain complaint was actually cardiac ischemia, which alludes to kind of the trickiness involved in treating and diagnosing these older patients, since they display like atypical symptoms compared to younger adults and have different underlying causes of abdominal pain, such as mesenteric ischemia and AAAs. So this is a high mortality and high morbidity condition, and yet we have seen significant practice variation. So the goals of our project were to characterize and evaluate the variability of this demographic. And so we used 5 years worth of data from NAHAMSIS, which of course is a national representative survey of US emergency departments. And so we looked at 82,000 visits to 1,200 emergency departments, which after survey weighting can be scaled to about 108 million emergency department visits by older adults. So we included any chart that listed the patient as 65 years old or older, and excluded any patient who was triaged to the ESI 1 or the immediate triage level, since the acuity of these patients did not allow for a reliable ascertainment of a chief complaint, which was our principal criteria for data selection. In Table 1, we have a comparison of characteristics of emergency department visits among older adults with and without chief complaint of abdominal pain. So on the in the right-hand column, we have those with abdominal pain, and in the left-hand column, we have patients who presented with some other chief complaints. And so when we look at ESI 2 triage level, so now we're considering this the highest triage level since we excluded ESI 1, we see that abdominal pain patients are triaged to this high level at about half the rate of their counterparts. And when we look at who is admitted to surgery, we see that abdominal pain patients are actually 4 times as likely to be admitted to surgery as compared to another patient with a different chief complaint. And so this kind of raises some concern that there may be systematic underestimation of the severity of this condition. Looking at Table 2, this is, we have the same columns, but we're looking at the evaluation and management strategies for these ED visits. And we see for abdominal CTs, which have been shown to be a highly effective form of diagnostic testing, about half our patients are receiving this excellent form of testing. Meanwhile, when we look at X-rays without ultrasounds or CTs, we have 16% of patients receiving no other form of diagnostic testing, or imaging testing besides an X-ray. And that's a little bit worrisome because X-rays have been shown in the literature to be an ineffective form of testing that actually provides false reassurance. And then if you recall, the leading cause of death for Medicare patients discharged with abdominal pain was cardiac ischemia. And so here we see that abdominal pain patients are less likely than another patient with a different chief complaint to receive an EKG. And this is also a minority of patients that are receiving an EKG. So overall, I guess the key takeaways would be this triage trend of the misalignment between emergent classification versus surgery rates. And so that's trend number one. We have another diagnostic trend where nearly 1 in 6 emergency department patients received only an X-ray for radiological evaluation. And so this kind of points to perhaps a trend in overutilization of more ineffective types of testing. And then this is compared to a minority of older patients who are receiving EKG, which is, a beneficial form of testing for the types of diagnoses we're getting from these patients. So we see perhaps an underutilization of these really more effective diagnostic tools. So overall, I think there's definitely general recognition in the emergency department that older adults are at higher risk for significant disease, but the optimal management of some disease processes can still be refined and to better align the treatment goals of older adults and the care delivered in emergency departments. So with that, I guess, are there any questions?
Terrific. Thank you so much, Rachel. And I see a question in the chat from Ari, but it was more of a prompt for the whole group. So Ari wants to provoke some conversation, which is great. So if folks have responses to that, put it in the chat thread. Rachel, I have a question for you, and maybe there's a question for you and Ari. So this data set that you have, it feels like there's some hidden information there about like who's getting EKGs, who's getting CAT scans. I assume you don't have vital signs or other information that might lend us to understand sort of the acuity. I mean, we have VSI classification perhaps, but sort of more of what's going on. You might imagine someone who's tachycardic and hypotensive to get a very different thing, or febrile to someone who has normal vitals, just as a very simple first pass. Thoughts on that?
Yeah. We do have vitals, Ben. It's a good point. I think in our first pass we looked and it was, a relatively low proportion of people had any vitals that we'd be, ignoring hypertension, which we all know we're not so excited about.
Right.
But it's a good point, like, especially like with as we explore like the ESI 2 versus 3s,
right.
We're kind of thinking of this as under triage, and I think that's the right framing because we've shown that it's higher, in other settings, we know it's higher morbidity, mortality. In this setting, we've shown it's higher resource use, which are the two things triage is kind of trying to capture. But a lot of that triage difference is loading on the 2s instead of the 3s, rather than the 4s and the 5s. So, there's a little bit of exploring to do there around, what's driving people towards the 2s. Maybe subgroup of 3s with normal vital signs are actually doing much worse because their scans are very much delayed. I think there's just so many interesting nuances here to explore. And then, kind of going into the really big data sets nationally and using, the Medicare data sets and things and starting to kind of explore bigger opportunities for greater measurement and kind of the disease process basis.
Thanks, Ari. I want to get to 2 other quick questions. I see Ben Sun and Dr. Alter have raised their hands. Dr. Sun.
This is great work. Congratulations. Just a suggestion to look at the group of people who had both an X-ray and CAT scan and or ultrasound. I think in contemporary emergency medicine, it's, at least for adult emergency medicine, there are probably very few cases where KUV is going to really be indicated. And so you might be doing an undercount if you exclude patients who had X-ray plus something else.
Thanks, Ben.
Dr. Alter, do you have a question? Oh, I think your microphone's off there, Dr. Alter.
Sorry. What Zoom meeting would be complete without that?
Absolutely, absolutely.
I first of all, I want to congratulate you, Rachel, and that was really a stunning presentation. Your abstract craft is well honed. But I want to ask if you've thought about looking at age as a dose response phenomenon. That would really, I think, give you a much more robust finding if you were able to demonstrate that across the continuum of age, that this is a progressively more dangerous practice. And you know, it's one of the more it's one of the things that we're able to demonstrate in clinical research that adds weight to an explanatory model is the dose response phenomenon. So, oh, well, there's the answer.
Yeah, but it's a great point, and I think there's a lot of interest in the geriatrics community and gerontology community about thinking about the oldest old, kind of 85 plus, as their own, you know, relatively unique population. They have different needs, and obviously it's a continuum, but that fortunately there's a nice cutoff that we could point to in the literature and say, you know, so the whole supplement to the paper is basically divides the whole paper back down by 65 to 84 versus 85 plus. And we do find that, you know, as you might expect, but I think lends credence to the general idea that the rates go up, but they by no means approach, you know, 100, or I think it's, you know, 75% maybe of 85 plus year olds with a chief complaint of abdominal pain wind up with cross-sectional imaging. So there's for a super high morbidity condition that's like as high mortality as a STEMI, it seems like there's potentially room for improvement. And there's also, you know, it may be like, that's not my experience at Penn. And so I wonder if there are places that are on older practice patterns or something like that, where they're more reliant on the KUB.
We should probably move on to our next speaker, but thanks and great questions and great discussion. So Rachel, we hope you continue your work with Ari. So now I guess we have the next Rachel, Dr. Rachel Gartland. Rachel, are you ready to share your slides and talk about your work?
I am ready.
All right.
Alrighty. Can you see me or my slides?
Yep, we can see you.
All right. Hey, everyone. I'm Rachel. I'm one of the fourth year EM residents, and I've been lucky enough to work with some incredible mentors, as you can see, on this resuscitation leadership training simulation curriculum for our EM residents. As you know, EM residents must learn so much throughout their training. So in addition to medical management and procedural skills, we also have to learn to be effective leaders in high stress, high acuity, and unpredictable situations. However, formal training for this is not consistent across all residencies. There are some frameworks that have been adapted to the medical field to teach some of these skills. For example, crisis resource management was initially created for aviation, and it teaches the clear allocation of responsibilities, closed loop communication, and situational awareness to provide effective leadership. Team STEPS was created by the military and likewise emphasizes leadership, communication, situational monitoring, and mutual support as tools for effective teamwork. So when combined with simulation, these frameworks can help us teach residents and have residents practice in a safe and controlled way. So we created this resuscitation leadership training curriculum to address this education gap for our junior EM residents. Our objectives were to provide a framework for improving our residents' leadership during resuscitations, to practice these skills using our high fidelity sim of critically ill patient scenarios, and to determine the curriculum's influence on the confidence and self-perceived effectiveness of the residents while leading resuscitations. So to do this, we had our PGY2 class from last year, so 12 junior EM residents participate in 8 sims. These cases were created to specifically address high yield teaching points in the medical management of critically ill patients. Groups of 3 or 4 residents would do one simulation, then they were given a didactic presentation about leadership skills using crisis resource management and team STEPS principles. They then did the rest of the cases. Each case was evaluated objectively by 2 faculty members. And then groups debriefed after the cases, discussing both the medical management as well as what went well or what could have been improved in terms of leadership and communication. At the end of each day, residents completed surveys that assessed their comfort in leadership, communication, and medical management skills. So after completing this curriculum, we found that residents felt significantly more ready to lead a resuscitation and felt their communication skills were significantly more effective. These scores were collected from the resident surveys done at the end of each session, and they were scaled on a score of 1 to 7, where 1 meant I'm not at all ready or I'm not at all effective, and 7 meant I feel very ready or very effective. All p-values here were less than 0.01. Residents also reported significantly higher comfort in managing each of these patient presentations after completing the curriculum. Again, the scores were given on a scale of 1 to 7, where 1 meant I'm not at all comfortable with this, and 7 meant I feel very comfortable managing this kind of patient. Again, all p-values were less than 0.01. So our study suggests that combining simulation with the teaching of these leadership skills frameworks like crisis resource management and team steps can improve not only the EM residents' abilities to lead and effectively communicate during resuscitations, but also may improve the residents' comfort in management of the medical aspects of these critically ill patients. Our data was limited by a small sample size, as our residency only has 12 to 13 or 11 residents per class. But as future classes go through the curriculum, we will strengthen this data with increased numbers. We also plan to assess the faculty gathered data on team performance that I spoke about as we had faculty members evaluate each case for a more objective evaluation of the curriculum. Obviously, simulation has obvious limitations compared to actual clinical scenarios. We use hand phones instead of real phones. Most importantly, though, we know that ED care teams include so many other people that work together to care for our patients. So we hope that future studies will be able to include nurses, techs, and the other staff that make up our ED teams. As the ability to lead these teams, though, while simultaneously managing complex medical cases is vital to safely caring for our patients, we hope that our curriculum will help create strong EM physician leaders and that it could be applied more broadly across medical training programs. Thank you for listening, and thank you especially to Mike Abood and all of the other incredible team that made this possible.
Great job, Rachel. And certainly resuscitation, full disclosure, resuscitation training is near and dear to my heart. So I especially love that. An encouragement and a question. You make a point that simulation can only get us part of the way there. And you may or may not be aware of some work recently published from Lance Becker and others at Northwell in New York, looking at video review for team training and debrief in cardiac arrest. And for those who aren't aware, we at Penn have a culture of video review for trauma education, but we really have not done so for cardiac arrest. And no one has, by the way. That's not unique to us. What do you think, Rachel? Can we do video reviews of actual cardiac arrest to encourage better resident training and leadership training? What do you think?
I think that would be great. I love our video reviews, especially our trauma video reviews. And I think it's really hard to watch yourself and listen to your own voice, but you learn a ton, and you learn, I think, more than just talking about it afterwards, even though debriefs are also amazing.
Well, how about you and me talk offline, and maybe that should be the next thing you target.
Perfect.
Awesome. Thanks, Rachel. That was great. Okay, and it's only a shame that we have to move so quickly through these talks, but we have just so much good stuff. Okay, so the next speaker is actually a visitor of sorts. She's not Penn EM in the truest sense, but she certainly is in the broader sense. We have tremendous collaborations with the trauma program at Penn. They're our friends, colleagues, and intellectual collaborators. Dr. Allie Hines, are you available to start your talk?
I am. I'm working on it.
Okay, working on it. So while she's working on that, Dr. Hines comes to us from the trauma program, where she's a surgical critical care fellow. And as you know, we do a lot of work with trauma, and our team has published a lot with trauma over the years. All right, Allie, Dr. Hines, take it away.
Hi, thank you for that wonderful introduction. I wanted to thank the Department of Emergency Medicine for allowing me to present our work along with Dr. Cannon. These are all of our disclosures. Trauma-related hemorrhage claims 50,000 lives every year, accounting for potentially the #1 cause of preventable trauma-related death. Damage control resuscitation improves survival on these severely bleeding patients. The landmark prompt and proper studies have affirmed the importance of balanced component ratios. However, this is difficult to achieve in clinical practice. We hypothesize that maintaining a balanced resuscitation during damage control resuscitation is independently associated with improved survival. Our primary objective was 24-hour survival, and our secondary objective was 30-day survival, respectively. First, using prompt, we selected patients undergoing a massive transfusion by the CAT positive or critical administration threshold definition. Specifically, we required 3 units of packed red blood cells in any 1 hour. Then we identified the optimal 6-hour cumulative ratio most strongly associated with 24-hour survival. We then assessed the importance of time spent during the resuscitation at or above this ratio. We also identified the optimal percent time from 24-hour survival. Then we defined 2 cohorts: on target for those patients who met both the ratio and time threshold, and off target for all other patients. Primary endpoint was survival at 24 hours, and secondary endpoint was survival at 30 days. Of the 1,245 prompt patients, 524 were CAT positive. Udin's index analysis identified the optimal ratio as 3 to 4 for both plasma and platelet to packed red blood cells. We found a consistent linear relationship between percent time above this 3 to 4 ratio threshold on the x-axis and survival probability on the y-axis. In this figure, the blue line indicates a significant positive correlation between percent time and survival for plasma to packed red blood cells, while the red line indicates the same for platelet to packed red blood cells. To summarize, this is depicting that with increased time above the optimal ratio, survival improves. Our Udin's index analysis identified 40% for optimal percent time. Then, using a ratio of 3 to 4 and a threshold of 40% time spent over that threshold, we then identified the on-target and off-target cohorts. We identified statistically significant differences in age, Glasgow Coma score, and INR, as noted on the slide. However, the on-target patients were actually more coagulopathic at baseline. Now, on-target patients are in blue and the off-target patients are in red. What you can see here is that there's an early separation in these curves that persist for both plasma on the left and the platelets on the right. This holds true out to 24 hours and out to 30 days. For 24-hour survival and 30-day survival, a number of variables were included in our multivariable logistic regression models and were independently associated with decreased survival. On the other hand, on-target plasma to packed red blood cells improved survival with an odds ratio of 2.25 and 1.97 for 24-hour survival and 30-day survival, respectively. On-target platelet to packed red blood cells did not improve survival. Finally, we noted that incrementally for every 30 minutes, 1 hour, or 3 hours at or above this optimal ratio for plasma to packed red blood cells, there was an independent association with significant improvement in 24-hour survival. Again, no such independent association existed for platelet to packed red blood cells. In summary, for the CAT positive cohort, there was an association with 24-hour and 30-day survival if the optimal ratio is maintained for at least 40% of the time on unadjusted analysis for both plasma and platelets to packed red blood cells. Multivariable logistic regression confirmed this independent association. Furthermore, for every 30 minutes, 1 hour, or 3 hour increments in maintaining the optimal ratio, There was also an independent association with improved survival. Limitations of our study included that this was a retrospective analysis, so data was not collected on all the confounding variables, including resuscitation adjuncts. Secondly, the platelets were transfused to a relatively small number of patients, so our results for platelet resuscitation were likely underpowered to detect a statistically significant value. Finally, we chose one analytical method for our optimal ratio calculation and percent time analysis, understanding that there are other methods and that each has their own unique limitations. In conclusion, our results showed that by maintaining a high ratio of plasma to packed red blood cells during damage control resuscitation is independently associated with improved survival at 24 hours and 30 days. Consequently, we advocate for capturing resuscitation ratios and percent time over an optimal ratio as important damage control resuscitation performance improvement metrics. Thank you.
Allie, thanks. That was great. And hopefully that gives everyone a little bit of a taste of some of the work our trauma colleagues are up to that very, very much impacts us as Level 1 Trauma Center and our thoughts on resuscitation and emergency care. I don't see any questions in the chat thread, but Allie, I have a question for you. So, and there's a bit of a leading question, but you know, that's my job. How are we going to prompt people? How are we going to get people to get what are some of the methods you might think about? Because, you know, the trauma bay is this busy, crazy place. Things are flying around. So focus on the right number of products in the right way. How are we going to fix that problem? And you can send me a check for that prompt later.
Well, only if there were different models and methods currently under investigation. I think everyone will be pleasantly surprised in the upcoming months to actively, and we're actually doing this currently now in our trauma bay, where there's an app that sits there and tracks how well you resuscitate, and it can serve as reminders.
Right, and that was sort of my my leading question. So folks who may, and for residents, nurses, attendings who are over there at Presby at the Trauma Bay, you may see this app in practice in coming months. We're collaborating actively with Jeremy Cannon and Allie and others on this to sort of guide resuscitation care, sort of smart prompting. Because as you all know, these exsanguinated patients, things get kind of gnarly, and sometimes we deviate off protocol. But anyway, Allie, thanks so much. Any other questions from others? No? Okay. I might also encourage anyone who's interested in critical care resuscitation and trauma type topics. Dr. Jeremy Cannon is the medical director of trauma, and he's a very active investigator in these areas and a mentor to many, and also a close collaborator of mine on a number of projects, including a DoD funded project looking at exsanguination and management of hemorrhagic shock. So if you're interested in these topics, students, residents, fellows, check out Jeremy and his work and Allie's work as well. Okay, great. So moving along in our original research presentations, next up is Dr. Utsa Khatri. Utsa, are you on and ready to roll? And while she's sharing her screen, I just want to give a shout out. Utsa has scored herself a fantastic job coming up at Sinai in New York City, where she'll be joining our former Penn EM faculty member Brendan Carr and others. We're super proud of her. Sad to see her go, but know she's going to do amazing things. So Utsa, the floor is yours.
Thanks so much, Ben, and thanks for having me today. I am presenting this project on behalf of our greater team, which includes Drs. Delgado, South, and Friedman. So this is Walter Wallace Jr. He was a father, a son, and an aspiring rap artist. At the age of 27, he was shot and killed by the police in West Philadelphia when he was experiencing a psychiatric decompensation of his bipolar disorder. He was brought to Presbyterian Hospital, already dead, but pronounced to be so in our trauma bay. After his killing, I thought a lot about how if he had been brought to the emergency department alive, perhaps we could have been able to help him. However, deep down inside, I knew that even in the hospital, the deeply embedded racism of our society would influence the treatment he could and would receive. This is especially true considering the racist undertones behind the management of psychiatric disease, as is evidenced by this advertisement for Haldol that was published in a premier psychiatric medical journal in 1974. So in this study, we sought to answer the question, is there an association between race and ethnicity and the receipt of chemical sedation in the emergency department for patients presenting with psychiatric disorders? So to go through the methods, we use the National Hospital Ambulatory Medical Survey database from years 2008 through 2018. And this is a national probability survey that uses ED chart abstraction. We included all visits that were for psychiatric disorders. And we use logistic regression models as well as marginal effects to report average adjusted probability in the outcomes of interest. Our main predictor variable was the patient's race, which was a marker for racism. And the main outcome of our study was the receipt of chemical sedation. The secondary outcome we also looked at that we won't share today is the definitive treatment for psychiatric disorders, which we defined in this study as either admission to a mental health or a detox unit or transfer to a psychiatric facility. And then we adjusted our models for the covariates of age, sex, pulse, presence of a chronic condition, region, EMS arrival, and night shift arrival. And so what did we find? This is just a summary of the table 1, just highlighting the main differences between, here we're just showing you non-Hispanic Black patients versus non-Hispanic white patients. Overall, compared to white patients presenting with psychiatric disorders, Black patients were slightly younger, slightly more likely to have Medicaid as their insurance, and slightly more likely to arrive during night shift. Also overall, when you waited for the national representation, there were about 5.1% of the visits that were deemed to be for a psychiatric disorder. There were slightly higher number of visits for psychiatric disorders among white patients compared to Black patients. But when you looked at the receipt of sedation within those visits, the unadjusted rates of receiving sedation were higher for Black patients. And so then when we controlled for patients' age, sex, initial pulse, the presence of a chronic medical condition, geographic region, EMS arrival, and night shift arrival, we found that Black patients were 1.79 times more likely to receive chemical sedation than white patients presenting for psychiatric disorders. Represented differently here, what we're showing you are the marginal effects of the regression model. So this is the rate in Black patients minus the rate in white patients. So when we looked at our primary model, there was a 2.2 percentage point higher likelihood of receiving chemical sedation among Black patients compared to white patients. In our second model, we included all of the covariates I listed to begin with, but also included whether or not accounted for the fact that the patient may have been admitted or transferred to a psychiatric facility. And when we did this, the difference, as you can see, was still significant between Black and white patients, but the magnitude was slightly less. And then, interestingly, when we used our primary model, but included a variable to account for the racial composition of patients seen by that particular hospital, the effect was no longer seen. And so to go into this a little bit further, what we did was we created a variable that represented the patients seen at that hospital that were either above or below the median proportion of Black patients. So in gray, these are all of the visits that occurred at hospitals that were below the median proportion of Black patients. And in blue, all of the visits that occurred at hospitals that were above the median proportion of Black patients. And overall, that racial disparity that we found in our first model no longer was present in the data, except, as you can see here with the confidence intervals, white patients presenting at mostly white hospitals were less likely to receive chemical sedation compared to Black patients presenting at mostly Black serving hospitals. And so why is this important? Well, there are decades of literature that show that emergency medicine care in particular has unique vulnerabilities to racial disparities and racial discrimination against our patients. And it's important from the patient's perspective because this is often the first and sometimes the only encounter they have with the health system at large. Much like Gina highlighted during her talk, this really highlights the importance of looking at data to identify sources of structural racism. What we're seeing here is that hospitals serving a higher proportion of Black patients are more likely to use sedation. And so really focusing on bias at the provider level would be insufficient to try to address this disparity we're seeing. And the last point that's important to make is that the previous literature on this shows that while most ED providers acknowledge that they've been trained on non-chemical or physical restraint use to de-escalate psychiatric patients, most people feel like they're ineffective. So obviously we need alternative approaches. Of course, the study has its limitations. Most importantly, the bias of the coder and the provider in documenting the reason for visit code is a major limitation. We also can't account for threats, either real or perceived, that may have led to the use of chemical sedation. We're unable to determine if the patient consented to receiving the sedation. Also, we can't since no patient identifiers were used, there might be patients that were represented multiple times with multiple encounters, and we can't assess for the use of physical restraints in this data set. So in conclusion, nationally, we found that Black patients presenting to the ED are more likely to receive chemical sedation than white patients for psychiatric complaints. And this appears to be because hospitals serving a high proportion of Black patients are more likely to use chemical sedation. I wanted to thank my research team and my mentors, not just for their help on this project, but really in life and in my research career thus far. And with that, I will take any questions.
So that was terrific. So any questions from the audience? And while we're seeing if anyone has questions there, maybe I'm not good at looking for the hands up thing. So if it's not in the thread, all right, just scan, don't see hands up. So oh, actually, Dr. Alter has a question. Great. Harrison.
You're muted, Dr. Alter.
I'll go after you, Ben. That's fine.
Oh, it's okay. No. My question is a good last question. So you next.
Well, this is a fantastic presentation, and it brings up so many questions. I do think that we have a problem when observing rare events in national data sets, that was brought forward by people who were skeptical about enhampsis and demonstrated that the majority of patients who were intubated in the emergency department had a discharge diagnosis of, or destination of home. So I think that we do get a little bit in trouble there, but I don't doubt at all your findings. And I love the way you framed them as not a racial disparity, but a disparity arising from racism. And Ted Corbin and I years ago proposed a thought experiment of going back through manuscripts in emergency medicine and replacing the word race with racism and seeing how that changed the shape of the landscape of emergency medicine evidence. I would say that there's an inference in the paper that all sedation is bad. And my experience as a clinician is that patients often feel a lot better after awaking from sedation when they're in a manic phase or experiencing extreme anxiety. And so it might be very difficult to tease that apart in the data set, but that may be related to people who were ultimately transferred, although the transfer may arise from the sedation in some cases too. So that might be hard to tease apart. But I do think you need to unpack a little bit that assumption that it's an act of last resort or whatever to provide chemical sedation to somebody experiencing extreme anxiety or mania from their mental illness. I don't know how to propose to do that. But.
No, absolutely. And thank you for bringing up that point. That actually comes up a lot when I talk about this paper, especially with my colleagues in psychiatry. But with the limited research that exists in this space, there are patient qualitative studies that have shown that patients who received physical or chemical restraints during an ED visit remember that encounter as one where they felt dehumanized, and that affected their care. And we also know that there are physiologic effects of the medications we use for sedation. And so while I think in some certain instances there might be a therapeutic effect, certainly, there shouldn't be a racial disparity in who is receiving the medications.
Absolutely.
Great. Actually, I'll defer my questions just so we can keep on schedule. But so that was great. Thank you so much. Okay, so our next speaker is Dr. Joe Lianza, one of our current residents. Those who don't know, Joe is actually going to be staying on, and we're thrilled to have him as our first global health fellow in the Department of Emergency Medicine. I'm working with Megan and others on global health issues. Joe, are you ready to share your slides?
Yep.
Fantastic.
Can you guys see my slides?
Yep, we can hear you and see your slides.
All right, cool. So I wanted to present some of the work that I've done in Uganda over the last few years. So the title of my presentation is Defining High-Risk Emergency Chief Complaints Through Data-Driven Triage. For those of you unfamiliar with the location of the world, this is Uganda right here, kind of Eastern Central Africa. Here's where I've spent a majority of my time, the town or city of Masaka. This is the Masaka Regional Referral Hospital. It's the current site of the emergency care practitioner program. I work with an NGO called Global Emergency Care. Over greater than a decade at this point, GEC has developed and administrates with local partners a 2-year training program for nurses and medical officers, sort of like PAs, through which the trainees become nationally certified emergency care practitioners and are certified to practice independently in Ugandan emergency units. This is the Nachibale Hospital in southwestern Uganda. It's like right near the border with the DRC. It's sort of close to Rwanda. And this is the original site of the ECP training program. The emergency unit has 6 beds, staffed exclusively by ECPs. They see about 500 patients per month, admit 60% with a 3-day mortality rate for admitted patients, somewhere between 3 and 4% a year, depending on the year. This is our classroom in Masaka. I'll use this to jump with a little bit of background. I think it's kind of indisputable that emergency medicine is underdeveloped worldwide. Uganda just graduated its first class of emergency medicine resident class. I think the World Bank kind of articulated it best in the 3rd edition of the Disease Control Priorities paper in saying that high quality emergency care is estimated to be able to address about 50% of annual morbidity and mortality in the world. That's pretty significant. This kind of thought has spurred the African Federation for EM, the WHO, the World Bank to call for a focus on EM research and investment throughout Africa. And through all this, the chief complaint has emerged as one of the research priorities, not only because it kind of guides diagnostic and therapeutic decision-making in the unit, but also because understanding chief complaints can enhance training and sort of optimize financial, diagnostic, and human resources, which are typically limited. The early part of this work and this talk was kind of spearheaded by my mentor, Brian Rice. This was published in BMJ Open in 2018. We took all of the free text paper charts over about a decade, converted them to Microsoft Access, and through some kind of fancy Stata natural language processing and an inter-rater consensus process involving both American and Ugandan practitioners. We kind of boiled down all of the free text stuff into a short list of emergency chief complaints that we thought could adequately and comprehensively describe the chief complaints presenting to our unit, or at least one of our units. This has further been refined and actually automated since, but it led us to the question, and the big question was, can the patient's chief complaint at triage be used to predict mortality? And this was our study. We just published it in Academic Emergency Medicine. We included all patients greater than 18 years of age who presented to the Nachibale Hospital in southwestern Uganda between 2009 and 2018, excluded pregnancy-related complaints. They went to a different ward, and patients who were DOA. And we looked at chief complaints, vitals, HIV status, 3-day mortality in both a derivation and validation data set in our study. I'm going to kind of breeze through the methods, but we employed recursive partitioning algorithms, sort of kind of a decision tree analysis in order to rank our chief complaints by mortality risk over 3 days. And we did this separately for patients with single and multiple complaints. We took the two lists and combined them through kind of other methods that I'm going to glaze over, and then employed this in our validation data set, and also ran multivariate model, like pretty basic logistic regression to understand if high-risk chief complaints were in fact associated with mortality risk in the department or in the unit. So here's our results. We had about 22,000 individuals in the derivation data set and about 7,500 in the validation data set. This is our high, medium, and low and zero risk chief complaint groups. You can see high risk includes difficulty speaking, vomiting of both blood and non-blood, both dysentery and non-bloody diarrhea, abdominal distension, unresponsiveness, shortness of breath, ingestion or poisoning, altered mental status, a lot of GI complaints there. Overall mortality was 2.76%, with additional independent mortality risk confirmed by old age, being HIV positive, presenting with hypo or hypertension, presenting with Brady or tachycardia, as well as hypothermia and abnormal AVPU, and also notably having a high-risk chief complaint. So overall, independent of vital signs, HIV status, et cetera, having one of those 12 high-risk chief complaints significantly predicted or was significantly associated with 3-day mortality. This was the first study to evaluate high-risk chief complaints in Uganda, and short of a couple of kind of subspecialty or niche studies, one of the few worldwide that's evaluated the riskiness of chief complaints at all. You'll see that mechanism-only complaints were not included in the high-risk list, and that's largely because high-risk features were already identified earlier in the algorithm, and therefore those charts were pulled out through the recursive partitioning algorithm. And then chief complaints that we generally kind of consider high risk in the US, like chest pain, for instance, were not high risk in the Nachibale Hospital. So in conclusion, I think this provides some actionable triage information, both kind of hypothetically and also anecdotally, having spoken to people in Uganda since completing this work. You know, I think this speaks to needing some local language and data to be involved in the research. And then our current projects are to combine this work with other triage risk scores like the TWS and MUSE to make a comprehensive triage risk score, and then perhaps separate this out for medical and traumatic complaints. This is 5 of my partners over there, and I'll leave it for questions with this nice sunset.
That was terrific, Joe. Great job getting all that content in. I have one quick question. I don't know much about emergency care structure in African countries. Do you think this is generalizable to other countries in Africa, like, say, for example, Botswana, where Penn has a lot of interest and engagement? Or do you expect, with your experience, that this would be very country to country specific based on sort of local conditions, urbanicity, and so forth?
Yeah, I think there are a couple of particulars to that. I think one is sort of the way that local language is structured, and kind of local cultural, societal descriptors of disease. And then part of it is kind of local disease patterns. The good thing about this is we sort of made the initial data refining process automatic, so that this can be portable to other locations, which I think is the important part. I mean, it requires a bit of a lift, but if you have the code, you can change the code a little bit, and
right. So it's adaptable, if nothing else.
It's adaptable, yeah. So yes and no.
Fantastic. Well, great. And we're really excited to have you continue your journey with us and teach us more about global health along with Megan in this new program. Great. So our next speaker, and boy, we are doing a great job staying right on schedule, which is surprising and wonderful all at the same time. Eden, I think now, Eden Engel-Rebitzer, thanks for being willing to switch. Are you ready to share your slides?
I am. Thank you.
Great.
So my name is Eden Engel-Rebitzer, and I'm a third-year medical student here at Penn. I'm going to be presenting a project entitled Patient Preference and Risk Assessment in Opioid Prescribing Disparities, a secondary analysis of a randomized controlled trial. We don't have anything to disclose, and I'd like to thank the large team of co-investigators, patient investigators, co-authors, and more, in particular, Fran Schofer and Zach Meisel, for their help in preparing these slides. Okay, so to start, some background. Black patients are less likely than white patients to receive opioids for acute pain in the ED. And this is unfortunately a very robust finding in the literature. However, there are some really important questions that are unanswered by existing research. And the first question is, it's unclear what role patient preference plays in these findings. It's been proposed that racial differences in patient pain management preference may contribute to prescribing disparities through a shared decision-making mechanism, but this is actually one of the first studies that directly examines the role of patient preference in driving opioid prescribing disparities for acute pain. And secondly, while there are a lot of theories about what mechanism underpins these disparities, it's really unclear what is the specific mechanism underlying opioid prescribing disparities, and as a result, it's unclear how to fix the problem. So we addressed that second limitation by proposing and testing a new theoretical mechanism driving disparities called inaccurate statistical discrimination, which is actually an old theory applied to a new question. So according to the theory of inaccurate statistical discrimination, disparities occur because decision makers have incomplete information about their patients. And in this case, decision makers are clinicians. So in the absence of complete information, clinicians may apply false generalizations about a group to individual members of that group to fill in a knowledge gap. For example, a provider may see a Black patient in the emergency department who has some unmeasured risk of misusing opioids, and the provider in that knowledge gap may then apply the false belief that Black patients are at higher risk of opioid misuse to that individual patient and then decline to prescribe them opioids. So in this study, we tested the hypothesis that inaccurate statistical discrimination is driving prescribing disparities by examining whether the disparities were impacted at all when providers were given additional information about their patients' pain management preferences and opioid misuse risk. So this was a secondary analysis of data collected for Life Storied. Some of you may be familiar with Life Storied. It's a large multi-center RCT that was conducted in the emergency departments of 4 academic medical centers. And we recruited patients who presented to the ED with either musculoskeletal back or neck pain or renal colic pain, and that were between 18 and 70 years old. And the outcome variables examined in this study included opioid prescription at discharge and preference treatment concordance. And you can see in the bottom right of your screen, we defined preference treatment concordance as agreement between the patient's preferred treatment modality and received treatment modality. So if a patient preferred opioids and received opioids, or did not prefer opioids and did not receive opioids, they were defined as receiving concordant treatment, and otherwise were defined as receiving discordant treatment. So once enrolled, patients were exposed to both a patient and a provider-facing intervention in this study, and only the impact of the provider-facing intervention was examined in this particular analysis. So providers of patients who are randomized to our treatment arm received the two forms you see on the screen. So on the left side of the screen, you see a form that was used to communicate patient opioid misuse risk to providers. So in this case, the provider was notified that their patient was at high risk for opioid misuse. And this was based on the opioid risk tool, which is a validated metric for predicting risk of opioid misuse. On the right side, you see a form that was used to communicate patients' preferred pain treatment preference to their providers. Okay, so most patients, both overall and in all racial groups, did not prefer opioids, were not prescribed opioids, and got the treatment that they wanted. That said, despite no differences in treatment preference by race, as you can see here, we found a marked difference by race in who actually got opioids. So 12% of Black patients versus 33% of white patients and 21% of all other patients actually received opioids. You'll see on the right side of your screen that there were no differences by race in the likelihood of getting your preferred treatment. So that said, when we looked at preference treatment concordance a little more granularly, differences between racial groups emerged. So among Black patients, the largest discordant group was patients who preferred opioids but didn't receive them at discharge. And you can see here 23% of Black patients were in this category, while only 6% of Black patients, which you can see here, were discordant because they didn't prefer opioids but were prescribed them anyway. Among white patients, the two types of discordance occurred at a similar rate. About 18% of white patients, technically the largest group of discordant white patients, didn't prefer opioids but was prescribed them anyway. Okay. So even after we accounted for other patient features, including demographics, presenting condition, pre-treatment pain level and triage, opioid misuse risk, we found, and this was all in a logistic regression model, we found that Black patients had less than half the odds of white patients of receiving an opioid script. And this was true among patients when we looked kind of overall, but also when we looked separately among patients that did and did not prefer opioids. So among patients that preferred opioids, Black patients had more than twice the odds of white patients of being denied them. And then conversely, among patients that did not want opioids, Black patients had about half the odds of similar white patients of being treated with opioids at discharge. Okay, so here you can see the results of our intervention. So we identified a significant interaction between race and presence in the experimental arm of our study. So when providers were exposed to our intervention, and again, that was the study arm in which providers were given additional information about their patient's treatment preference and opioid misuse risk, it actually appeared to exacerbate racial disparities in receipt of an opioid prescription. So you can see here at the bivariate level, the control arm in blue and the experimental arm in red. In the experimental arm, you can see a bigger decrease in odds of receiving opioids when you move from the white group to the Black group than you do among the control group. And this same pattern emerged when we looked at this interaction in our full multivariate model. So in terms of our conclusions, we found that even in the context of a rigorous RCT, Black patients in the ED were less likely than white patients to receive opioids for acute pain. And when patients didn't receive their preferred treatment, we found that white patients received opioids more often than they preferred, and Black patients received opioids less often than they preferred. We also found that in contrast to some theory in the literature, these disparities were not explained by differences in pain management preference, and they were also not eliminated by assessing and providing prescribers with patient treatment preference and risk of opioid misuse risk. And future research, I think, here should further examine alternative causal mechanisms underpinning these prescribing disparities as part of an effort to eliminate them. Thank you so much.
Thanks, Eden. That was terrific. Really important work, and I think it highlights a lot of the efforts underway in our department too to look at opioids from all kinds of angles: utilization, race, perspective, addiction, et cetera, et cetera. So thank you for that. Just to keep on schedule, I hope you don't mind if we move on without a question, but please, folks, do put questions in the chat thread, and I know Eden will be around to answer them and to engage in more discussions. So thank you, Eden. Really appreciate it. Okay, great. So our next speaker, and actually we have two more speakers today, so please do hang with us if you can. Great science ahead. Our next speaker is going to be David Helfer, who is a medical student at PSOM as well. So we've had a lot of medical students today. Go PSOM Med School, it's amazing. David is going to be presenting on some of the work I've done with him and learned from him about post-arrest cardiac cath. David, take it away.
Awesome. Thanks, Dr. Arbella, for the introduction. Hi, everyone. Really a pleasure and an honor to be here. My name is David Helfer. I'm a second-year medical student here at Penn. Today, I'll be presenting on our project looking at clinical factors associated with significant coronary lesions following out-of-hospital cardiac arrest. Big thanks to Dr. Arbella for his mentorship and guidance in the project. No financial disclosures. I want to recognize the EMF and SAEM Foundation for their support of this research. A little bit of background. So out-of-hospital cardiac arrest afflicts over 350,000 people in the United States each year, with less than 20% survival to discharge. Significant coronary artery disease has been identified in over 70% of patients who have been resuscitated following out-of-hospital cardiac arrest. And coronary angiography with subsequent PCI is associated with improved morbidity and mortality. With that said, broad clinical uncertainty still remains over which patients would do best or would be the best candidates for coronary angiography, especially in the setting or in the absence of ST segment elevations on their post-arrest EKG. Our hypothesis was that there could be early clinical factors that would be associated with significant coronary lesions after a cardiac arrest. And potential factors we were considering was past medical history of myocardial infarction, coronary artery disease, as well as symptoms of acute coronary syndrome either before or around the time of the arrest. And in addition, of course, EKG findings. So if true, if we could characterize these and help figure out their associations, they could be helpful in make physicians who are trying to make these decisions of who to send to the cath lab. So we did a multi-center cohort study looking at adult patients from atraumatic out-of-hospital cardiac arrest who went on to receive coronary angiography during their subsequent admission. We looked at a 5-year time period, and we used a combination of what was found in the emergency, the EMS run sheet, the ambulance sheet, as well as what we could find in the emergency department and the hospital records. I'd like to thank some of our collaborators all at Temple Health, Christiana Care, and Reading Hospital specifically for contributing cases. Really helpful to take a look at sort of the Southeast Pennsylvania, Delaware region. I don't have time to get into this, but I thought I'd include it since there's a lot of Penn folks on here and potential collaborators. This is sort of a look at what type of information we were able to capture and what variables we were able to find in the EMS run sheets. Primary outcome was clinically significant coronary artery disease, which for this study we defined as greater than 50% stenosis of the left main, or greater than 75% stenosis of the other coronary arteries, which was sort of consistent with similar work in the literature. Secondary outcomes looking at whether or not they had PCI performed, as well as survival and neurologic impairment. In total, we had 331 patients who we looked at, median age of 60, about a third were female, a third were Black, and a median BMI of 30. In a univariate analysis, we found that those with significant lesions were more likely to be older, were actually less likely to be female, and less likely to be Black. In terms of acute coronary syndromes, the top 3 reported are in this table here. 24% reported chest discomfort prior to arrest, so that includes chest pain, chest discomfort, and those sorts of terms. They were more likely to have significant lesions if they reported that. Initial shockable rhythm as well associated with significant lesions. Looking at past medical history, having a history of coronary artery disease in their chart, high cholesterol, prior MI, or a prior cardiac arrest in the univariate analysis were all more likely to have had significant lesions present. And similarly, looking at ST elevations or depressions, or having an initial positive troponin greater than 0.04, those with lesions were more likely to have each of these. Taking a look at some of our outcomes, about half ended up receiving PCI of the 331. The mortality was about half in our population. And interestingly, it was the same in those who had significant lesions and those who didn't have significant lesions. So the mortality was the same there. Median ICU stay of about 4 to 5 days. In terms of what was found on angiography, 1/3 of patients actually didn't have any significant lesions identified, but the majority did, with about 14% having significant multi-vessel greater than 3 vessels involved. So here is what's presented as our multivariable logistic regression results. And we found, so you can see in the table on the left, sort of the chart, these are the odds ratios plotted with the confidence intervals. You'll see history of myocardial infarction was actually the most significant, at least in our study, predictor or having an association with greater than at least 1 significant lesion identified on coronary angiography. And I think one of our important findings is that chest discomfort actually had an odds ratio of 7, which is a bit surprising. We think is important, which was even greater than that of ST elevations, which was 3. Others that were significant were having ST depressions on the post-arrest EKG, as well as identifying as male gender and as having a initial shockable rhythm of their arrest. A couple limitations in this study, obviously being retrospective, we are beholden to the selection bias in that we don't have any information on those patients who did not receive coronary angiography or did not get ROSC in time to undergo that procedure. So we can't really look at those. And in addition, some incompleteness or missingness in the run sheets and in the documentation of acute coronary syndrome symptoms. We acknowledge that the nature of out-of-hospital cardiac arrest is sudden by definition, and sometimes those are hard to capture, but we were able to capture them in a lot of our patients. And so more work, I think, needs to be done in this area to sort of help characterize how frequent these symptoms, and help characterize their association. So some conclusions: report of chest discomfort prior to arrest, history of MI, ST segment elevations, and depressions were, as well as initial shockable rhythm, were all independently associated with presence of significant disease. And we think that these factors in combination could have some potential in creating some prediction tools for who would benefit from having cath after out-of-hospital cardiac arrest. Here's some of my acknowledgements. Thanks to the team here at Penn. Happy to take any questions.
David, superb as always. I've heard you present before and it keeps getting better. Folks, any questions from the audience or the group? And certainly I could ask questions, but I was part of the work, so it's less exciting for me to hear questions. But maybe I'll just ask one just for the fun of it, David, in case anyone else doesn't have a question. So, this is going to be a paper. And by the way, everyone, David's writing up a manuscript for submission as we speak that will probably go to a high impact journal. This is going to be the first multi-center demonstration that pre-arrival symptoms, pre-arrest symptoms correlate with a cath finding and might influence the role of cath. We don't often get this sort of information. EMS often drops and runs, or EMS may not actually have the time to ask family members about pre-arrest symptoms. Let's say this is really true. Let's say finding out if patients had pre-arrest chest discomfort is really important for clinical decision making. How are we going to solve that problem? How are we going to address that and get this information in real time from family members? What would you think?
That's a really great question. I mean, obviously, if we're going to embark on this sort of work, it's good to think down the line if we do find something that's as significant as it was here, how to make that actionable. I think there's a few things. I think this is important for emergency medicine, pre-hospital providers to understand, because they're really the only ones that we can trust. Us in the hospital can trust as being there on the scene. And so if they are asking people who are around, hey, did this person have chest discomfort? I think we could learn a lot from that. And I think also from sort of the emergency department perspective, making sure that you're that you're asking the EMT or the paramedic who's coming in to say, hey, you know, was it documented that they had any of these symptoms, such and such, right? I think that, you know, we'll see what we find. It's sort of hard to tell.
Yeah, and I think that's a thought, you know, making EMS is very good at checklists. And if you make it a box to check, you know, did you ask family on scene about symptoms? It could take 5 seconds, but we'll have to think more about how to action this for future sort of work. Terrific. Well, thanks for doing that. And again, amazing contributions from Penn medical students to EM research. We really welcome all of you guys on this. And as a segue, here we have another medical student, Eric Winter, who will be presenting on some work related to trauma. And again, trauma collaborations with emergency medicine. Eric, take it away.
All right. Well, thank you so much for having me today. Let me just share my screen quickly for you, and we'll get started. All right. Can somebody confirm if they're able to see my screen right now?
Yep, we can see you and hear you.
Outstanding. Okay. We're going to go back. Okay. So this study is titled Police Transport for Penetrating Trauma. My name is Eric Winter, and as mentioned, I'm a third-year medical student at the University of Pennsylvania. This data was previously published in the journal JAMA Open. So penetrating injuries cause over 42,000 deaths in the United States annually. And despite recent advances in hospital-based resuscitation practices, pre-hospital deaths from penetrating trauma have risen steadily for the last 15 years. The time required to transport penetrating trauma patients to the hospital has been shown to be a significant predictor of mortality. And although emergency medical services or EMS personnel typically perform pre-hospital medical care and provide rapid transport to the hospital, police officers may also be able to provide safe hospital transport for patients with life-threatening penetrating injuries. In 1996, a policy directive in Philadelphia instructed police officers to transport patients with serious penetrating wounds directly to accredited trauma centers, and advised that transport should not be delayed to await the arrival of EMS. And so, despite increased acceptance of this practice, patient outcomes haven't recently been assessed to determine the impact and the safety of police-based hospital transport. The present study addresses this gap in the literature and hypothesizes that penetrating trauma patients transported by police have lower mortality than patients transported by EMS. So let's take a closer look at the design of this investigation. This study obtained patient data from the Pennsylvania Trauma Outcome Study Registry, which contains information for about 5,600 penetrating trauma patients in Philly between 2014 and 2018. The patient sample for this study included all adult victims of penetrating trauma who were taken directly from the injury location to a level 1 or a level 2 trauma center in Philadelphia by police officers or EMS. Patients transferred from other care facilities and patients arriving by private vehicle were excluded. And so after data cleaning, patients were separated by transport method. And then at this point, logistic regression was performed to compare mortality rates between transport groups. After whole cohort outcomes analysis, non-transport patient characteristics, potential confounding variables, were identified. And these included injury mechanism, defined as a firearm or a cutting instrument, location injury and severity, defined by overall injury severity score and body region, patient age, and presenting vitals, including systolic blood pressure and Glasgow Coma score. Data was binned or coarsened to create discrete categories within each matching criterion. So for example, patient age was classified as 18 to 45, 46 to 65, or greater than 65. Patient's unique combination of matching criteria bins is represented as a color in this particular figure. And so then coarsened exact matching was performed. Matches were sought between patients with different transport methods, so police or EMS, but an otherwise identical combination of matching criteria bins. Unmatched patients were removed from the data set and not included in further analysis. And then the resulting matched groups differed only with respect to transport method and had otherwise matched patient composition. And so finally, patient mortality was then compared between matched cohorts. The primary endpoint for this study was mortality within 24 hours of hospital arrival. Secondary endpoints included mortality during overall hospitalization, on hospital arrival, and at 1 hour and 6 hour post-arrival time points. So to quickly orient you to this figure, along the x-axis, you can see the odds ratio for mortality with higher police mortality to the right. On the y-axis, you can see the results for whole cohort and matched cohort outcomes at different time points. So in the whole cohort unadjusted analysis, the police transported patients were significantly younger, they were more often shot, and they had higher injury severity scores than EMS transported patients. Patients transported by police officers were found to have significantly higher mortality than EMS transported patients at all time points. In the matched cohorts, there were no significant differences between transport groups with respect to patient age, injury severity, or presenting vitals. And also importantly, there was no difference in patient mortality for police versus EMS transported patients. So then subgroup analysis was undertaken to assess mortality for patients with different levels of injury severity determined by injury severity score. This particular figure displays 24-hour mortality and mortality on hospital arrival for patients with different injury severity scores. So in whole cohort analysis, less severely injured patients had higher 24-hour mortality when transported by police. But when injury mechanism and severity are controlled, there was no difference in 24-hour mortality for any level of injury severity. And interestingly, penetrating trauma patients with the most severe injuries have lower mortality on hospital arrival when transported by police officers. So overall, this study suggests that police officers are able to provide a safe and effective means of transport for penetrating trauma patients that should be considered complementary to EMS transport. Timely transport should be prioritized over medical capability in the pre-hospital care for penetrating trauma patients, and future studies should quantify differences in transport time and demonstrate the effect of pre-hospital interventions on time to definitive hemostasis and patient survival. Thank you.
That was terrific. Thanks, Eric. And, you know, I think it's worth a general mention to the group that Philadelphia's got sort of a unique perspective with regarding police transport of significant trauma. Some cities don't do this at all. The police have no, so it's a very local and political environmental thing, but there's been a very strong culture in Philadelphia for a number of years of police drop-offs, and it's had important alterations in trauma flow and impact and largely beneficial impact. Anyone have any questions for Eric? So Eric, I would ask one question. I don't know enough about police. Are all Philly police made equal? And that is to say, are there different levels of police? For example, and the reason why I raise this, in EMS, there's sort of primary response, secondary response vehicles, there's lieutenants who show up. In your experience or looking through some of these data, is it usually sort of a police officer just scoops and runs, or sometimes are there sort of higher level police that get involved in some of these trauma situations?
So that's a fascinating question, and I thank you for it. The overall objective of this particular policy is to transport patients to the hospital as rapidly as possible when they have penetrating injuries. And as a result of that, there is very little medical care that is provided by police officers for these patients. So in that way, there's not really levels of intervention that police officers are providing or different tiers. It really is scoop and run, as you said.
Right.
If they identify a patient with a gunshot wound or other severe penetrating injury, they're going to take them in the back of a squad car to the nearest trauma center without any intervention. That being said, a recent initiative has outfitted all of the patrol officers in Philadelphia with tourniquets. And that the objective of that policy is to give them an improved ability to control extremity hemorrhage in serious emergencies. And so in very rare situations, patients can show up to the trauma center with a tourniquet in place on an extremity, but that's about the extent of pre-hospital medical care that is provided by police officers. And again, that's much less common than just the standard scoop and run.
Right. That was helpful. Thank you. Well, thanks, Eric. And with that, thanks to everyone involved in Research Day. This has been great. A couple of little final housekeeping items. Faculty and residents, you may have received an email from Gina South about a culture of care survey with regard to racial, structural racism and racial disparities. Please do fill out that survey if you've received it in the last few days. Others, please do send me your feedback if you liked Research Day, what you liked, what you think we should do differently. We're always looking for new ideas. Finally, I want to give a big thank you to everyone who's on the Research Day committee. So this was certainly a team effort. When we do it live, I prefer other people to be the MCs, but it was just easier structurally this way. So I just want to mention them. Nabil Abdulhay, Anish Agarwal, Eliana Jalkowski, Eileen McDonald, Rachel McFadden, Libby Moore, Franz Schofer, and Kaitlina Stillman. So thanks to all of you for being part of the Research Day committee, reviewing abstracts and helping put this together. And with that, we look forward to returning in person next year, God willing, to have Research Day 2022. And once again, I want to thank Dr. Harrison Alter for joining us. And thank you also, Dr. Alter, for staying with us the whole day and contributing and asking questions. It was really the meaningful interchange we were hoping for, and we hope to stay in touch as much of our research agenda moves forward in alignment with a lot of your work. So thanks, everyone. Have a great day. Stay safe. Encourage vaccinations, and we'll see you again soon. Thus concludes Research Day. Thanks, Harrison.